So today is the day for OBGY. Now OBGY, I am Dr. Sonal Parihar, your OBGY consultant, your tutor at Manipal Medace. Hi Dr. Nareen. So why we are doing this? Because see, you all are studying, right? You are preparing for NEET PG, you are preparing for INI-CET, but our motive is to bring something innovative, something different for you, because every tutor has a different way of teaching. You might gain from something that we tell you, and you also need some brushing, some push from the teachers who have been practicing for so long, teaching for so long. So yes, it will help you in defining and making a strategy for yourself. Now this is just 1 month left, okay? So I want you, all of you, to realize that you have to start studying very seriously now. It should raise some goosebumps in you. If it doesn't raise any goosebumps, that means you're not prepared. That means you're not serious. So if you're serious, all these live sessions are going to raise some goosebumps and tell you exactly where you are failing and where you are lacking, okay? So today, because it's a big subject, let's not waste time. I have already asked some of you who are connected with me as to what topics you want me to cover, because OBGY is vast. It's very, very vast, okay? At Manipal Medace, we already have those, the app is there. You can purchase the entire thing. You can purchase the summary things, and if you want to just go for the live sessions, the PDFs, then it is there in the free trial. So you can just subscribe to that and you can go for the free trials. You can get these PDFs, whatever we are teaching. But what I want to tell you is, whenever we do the summary, any subject, whether it's a minor subject or a major subject, it will take around 10 to 15 hours, sometimes even 20 hours. On YouTube, we don't go more than 2 hours, maximum 3 hours. That is the maximum capacity a student can stay with us. So let's not waste time. I have selected some topics according to the PYQs and according to what you have asked me to discuss, because certain topics are difficult for you. You don't know how to approach the questions. So let's start now. Hello, Dr. Abhishek. So I'm Dr. Sonal Parihar. The topics that I have selected for today, I hope I'm able to finish it by the end of this session. Magnesium sulfate and PIH, that's a very high yield topic. I can see so many questions on magnesium sulfate. Genital cancers you have requested. Out of these, the most important is the cervical cancer. The most important is cervical cancer and CIN. You may get a question on postmenopausal bleeding when it kind of takes into account the endometrial cancer. Ovarian cancer, you may get something like pathology, the typical appearances of ovarian cancer. Staging you might get, staging laparotomy you might get, but the most important is cervical cancer and CIN. Hello, Dr. Ranjana. Hello, KK. Then the next topic that I have selected is GTN. That is again a part of genital cancers. DSDs you have requested. It is disorders of sexual development. Amenorrhea, primary and secondary. We will touch normal and abnormal puberty. I will not go through the embryology because that must have been covered by anatomy in your anatomy lectures. GDM, very important, high yield. Among the medical complications in pregnancy, diabetes and anemia is something you should know. It should be on your fingertips. Very, very important. Because India is an anemic state and India is a diabetic state. So these two diseases are very important. Bishop score, I have just kept one question so that I can see how much you have revised your Bishop and modified Bishop score. Robson's classification is again just something you have to mug up, but I will tell you how to remember if it is difficult for you, because I have been practicing for 25 years, so it is easy for me to remember. It is just kind of what all criteria they are putting in 1, 2, 3, 4, 5, 6, how they make it 10. Okay, so that becomes easy. And then the last will be partogram, because one of you has requested, ma'am, we can't understand partogram. We cannot understand how to approach the question. So the last will be partogram. Okay, so quickly we'll go through the PYQs, the answers and the text related to that. Now, answer this question for me. A 33 weeks multigravida woman presents with epigastric pain, headache, visual symptoms and proteinuria 3+. So that rings a bell. It is a severe PET, right? Severe PET, but she's a preterm. She's 33 weeks and she's a multi. So these are the 3 pointers which are important. 33 weeks, multigravida and severe PET. What is the next step of management? Tell me. I give you 20 seconds. There is a little lag, so I know whenever you will answer, I will take some time to realize that you've answered. So I give you 20 seconds and then I'll start with the answer. So will you do an emergent cesarean section in this patient? You will give her dextromethasone for fetal lung maturity because she's preterm. You will induce for vaginal delivery. They haven't told you what is the vaginal condition, whether the Bishop score is good or not. And whether you will give a magnesium sulfate IV initially. Hello, Himanshi. Hello, Sanjay. Okay. 25 seconds have gone, so let me tell you the answer. The answer is magnesium sulfate. It is magnesium sulfate. Yes, KK, that's right. It's magnesium sulfate. Why? Because the first thing is the patient is having imminent symptoms of eclampsia. You don't want her to convulse because then that will increase the maternal and the fetal mortality. right? Mortality and morbidity. So first you have to control the symptoms of eclampsia. So you give her magnesium sulfate. Once she is stabilized, you give her antihypertensives to control her blood pressure. Then you give her corticosteroids. If the time allows, you can give her corticosteroids after 24 hours, the second dose, or you can give her after 12 hours, the second dose can be given. Sometimes even when you have to hasten the delivery, you have to deliver her on the same day, you can just give her one single dose. That is also very effective according to ACOG. One single dose can be given. So the first thing is magnesium sulfate. Second will be antihypertensive therapy. Side by side, you will give her steroid dose. Then you will assess her. If the drugs are working well, then you may postpone the pregnancy for another 2-3 weeks. You may take her to term if possible. Delivery may be delayed for a few days depending upon the response of these drugs. Next question. Which of the following is not true regarding magnesium sulfate? What is wrong here? Magnesium sulfate will cause uterine relaxation, but it is dose dependent. Magnesium sulfate is continued 24 hours up to delivery or last attack of seizure, whichever comes late. It has an inhibitory effect on cerebral cortex, thereby preventing seizure and lowering the blood pressure. In renal failure, the magnesium sulfate loading dose can be given, but the maintenance dose should be adjusted based upon the renal function. Okay, I'm setting the time again, 20 seconds for you to go. What is wrong here? Everything looks absolutely normal and right, absolutely true, but there is something which is wrong. Okay, your time is up. 20 seconds have gone. No answer yet? Okay, so the answer is C. What is C? Inhibitory effect on the cerebral cortex is right, but it is not going to cause lowering of blood pressure. This is wrong. It is not an antihypertensive. Remember children, it's very, very important. Magnesium sulfate is not an epileptic drug. It is not an anti-epileptic. It is just going to cause vasodilatation. It is going to reduce the transmission of acetylcholine that reduces the current flowing in the brain. So that is an inhibitory effect on the cerebral cortex that reduces convulsions and seizures. Okay, but it is not used as an antihypertensive. It is not used as an anti-epileptic drug. It controls fits effectively without any depression. If it is within the therapeutic range, it will not cause any depression to the mother or the fetus. It is not given to treat hypertension. It reduces the risk of recurrent convulsions. Very, very important for you to remember. It is a drug of choice for prevention and treatment of convulsions only. Magnesium sulfate is indicated only in convulsions. Okay. Significantly reduces the maternal death rate by 3% and reduces the perinatal mortality rate also. Yes, it is neuroprotective, you're right, but it is not causing any decrease in the blood pressure. Then, what is the mechanism of action? Just quickly recapitulating what you have read. It will block the NMDA receptors in brain, right? It has an inhibitory effect on cerebral cortex. It decreases the release of acetylcholine. The neurotransmitters decrease. So, the current flowing in the brain will decrease. That is why the brain becomes silent and the seizures reduce. It will cause cerebral vasodilatation. So, it will prevent cerebral hemorrhage, the most important cause of death in eclampsia. It will block the calcium channel blockers. Remember this. There was a question. There were a number of antihypertensives written as to all like labetalol, nifedipine and all. So one of them you have to choose which has to be used with caution along with magnesium sulfate. And what is that? That is calcium channel blocker. Calcium channel blockers will have a synergistic action with magnesium sulfate because both of them will act on calcium channels and they will block the channels. So calcium deficiency can happen. So it will stabilize the cell membrane by blocking these channels and decreases the intracranial edema. Now, it is excreted totally by the kidney. So that is the reason why this option is absolutely correct. It is not false. In renal failure, it is not because of magnesium toxicity that renal failure is happening. In renal failure, the magnesium excretion will be hampered because the renal system, the kidneys are not able to excrete it, and that will lead to in turn magnesium toxicity. So you will give a loading dose, but you will not give maintenance dose unless you make sure that there is no toxicity. Okay, so it is excreted by renal system. Short-term tocolytic, as you said, KK, that it has a neuroprotective action, but the problem is that when you are giving it at less than 32 weeks, patient who is in preterm labor at less than 32 weeks for the cerebral protection of the baby, at that time you have to be very sure that the magnesium toxicity is not happening because the therapeutic dose is between 4 to 7 milliequivalents, but here it has to be 8 to 10 milliequivalents to act. So you are actually crossing that safety value, the safe therapeutic range of magnesium sulfate to give it the benefit of preterm labor. So it is not used as a tocolytic. Okay, so that you have to remember. Now, the therapeutic range, they might ask you, it's a very important question. Different values, different units will be different. So the most important that they will ask you, or the most important one which is there in your books, is 4 to 7 milliequivalents per liter. Hello, Dr. Vinay. 4 to 7 milliequivalents. But if they change the unit, remember it's INI-CET, they can do anything. Okay, so if it's millimoles or if it's milligram per deciliter, the value will change. So it is not 4 to 7, it will be 2 to 3.5 millimoles per liter. This is also per liter, but when it comes to milligram per deciliter, it becomes 4.8 to 8.4. So just mug it up. You have to learn this. All three units are very, very important. Hello, Dr. Meenakshi. So till 24 hours after delivery or the last seizure, whichever appears late. So if she has delivered and she did not have any seizure after that, so after she delivers, from there till 24 hours, you continue magnesium sulfate, then stop it. But in case she has a conversion after delivery, then you have to calculate those 24 hours from the time she had a conversion. Okay. Caution is it will block the peripheral calcium channel. So use it with caution in women who are already on calcium channel blockers. Absolute contraindication will be of magnesium sulfate will be myasthenia gravis, because you don't want to reduce the acetylcholine transmission. Already they are under respiratory depression. You don't want that. And deranged renal function, because that will lead to accumulation of magnesium in the blood. Hello, Samta. Now, magnesium sulfate can cross placenta and it can lead to some effects on the fetal heart also. That is the reason most of the clinicians will, like for example, when I was working in BHU, I was doing my PG. We at 3 a.m. always, we were like, the first years were ready with their magnesium sulfate kit, because in BHU we got the peripheral villages and the Bihar trains coming from Bihar and the peripheral areas, West Bengal. So at 3 a.m. 2:30 a.m. there would be one eclampsia every day. Every day, every night we will get one eclampsia and one rupture uterus. Those were the days 97, 1997, 98, 99. These 3 years when I was my PG student, we used to wait for these patients. So there will be some effects on the fetal heart. So the first thing is the magnesium sulfate kit is ready. You have to stabilize the patient. You have to check the baby is live or not. And you have to quickly transfer the patient for delivery, either in the labor room or cesarean. So what I want to tell you is magnesium sulfate can have deleterious effect on the baby's heart also. Okay, so it can cause what? It can cause decreased beat to beat variability, and it can also lead to bradycardia and prolonged deceleration, something like this. These are prolonged decelerations because of hypoxia. The patient herself is hypoxic. Oxygen saturation is less. So the baby will also get less oxygen. Okay. So a woman with eclampsia, answer this for me. Again, I'll put a timer. Woman with eclampsia is started on magnesium sulfate. What is the first sign of magnesium sulfate toxicity? Come on, it's very easy. Hypotension, low blood pressure, loss of knee jerk, reduced muscle tone, or respiratory depression. Very simple. Answer this for me. You get only 15 seconds this time. It was the simplest question I can put for magnesium sulfate. Good, KK. It is loss of knee jerk. So the deep tendon reflexes are the first ones to go, and you have to keep checking to check for the magnesium toxicity. So assess the deep tendon reflexes periodically. Disappearance of the patellar reflex is the first sign of impending toxicity. Apart from that, what else can happen? Apart from that, diaphoresis, excessive sweating, slurring of speech, confusion, and flushing can happen when the patient is getting magnesium toxicity. So the first thing to disappear will be patellar reflex, and this happens at around 10 milliequivalents per liter. So the therapeutic range is 4 to 7. Once it reaches 10, the deep tendon reflexes will be gone. There is a narrow range at which therapeutic effect and toxic effects of magnesium occurs. Therefore, monitoring of magnesium toxicity is very, very essential. Thank you, Sanjay. It is 2 yes. So patellar reflex lost at 10 milliequivalents. Once it reaches 12 or more, it can cause respiratory depression. Paralysis, respiratory arrest can happen after 15. After 25, it will be cardiac arrest. Okay. So these two things have to be prevented. These two we can still manage. We can still manage by giving an antidote. Calcium gluconate, calcium chloride can be given. 10 ml of injection of 10% calcium gluconate, 1 gram IV or calcium chloride can be given as an antidote. Okay. This is all about magnesium sulfate. Another thing you need to know about magnesium sulfate is if there is oliguria, I told you, if there is renal compromise, then you have to measure serum creatinine. If serum creatinine is getting high, if it is more than 1 milligram per deciliter, that means the creatinine is accumulating in the body and the renal system is failing. In that case, you have to measure serum magnesium levels serially to decide the infusion rate. If at all the magnesium level is rising above 7 milliequivalents per liter, that means you know that the magnesium is accumulating and the infusion rate has to be decreased. Okay. Oliguria is not a sign of magnesium toxicity. I just told you it is because of poor excretion from the kidneys that the magnesium will accumulate. Best marker of magnesium toxicity. Now, you know that respiratory, first of all, it is DTR, deep tendon reflex, then respiratory depression, then respiratory paralysis, then cardiac paralysis, cardiac arrest. Now, you don't want to go to respiratory arrest and cardiac arrest. So, what will you do? You will just put a pulse oximeter. You cannot send the magnesium blood levels again and again to the lab and ask the lab to tell you the value of the magnesium in the blood. So what you can do is simply put a pulse oximeter on the finger, and there is a reduced oxygen saturation without oxygen. The patient is not on oxygen. On air, if she is having less than 90% saturation, that means she is going towards respiratory depression and magnesium toxicity is happening. So if they ask you what is the best marker of magnesium toxicity, it is pulse oximetry. Okay. Now, the loading dose, again a very favorite question of the examiners, loading dose of max salt in preeclampsia. Now, when you become a resident in OBGY, you will come to know this, because every day you will get an eclampsia. Maybe not that frequently as I used to get when I was doing my PG, but yes, you will have that magnesium sulfate, the yellow ampules will be there. So, is it 4 ml in 16 ml? So, 4 plus 16 is 20. This is also 8 plus 12 is 20. Okay. Then 12 plus 8 is also 20. So, they have purposely given this. Tell me the answer. 4 ml in 16 ml NS, 8 ml in 12 ml NS, 12 ml in 8 ml NS, or 10 ml magnesium sulfate. Everywhere it is 50%, because we know that the ampule is 50%, so they have not changed this. 50% magnesium sulfate is there in the ampule. Okay, KK, you are saying C. Are you sure? You want to check this again? Okay, so I've already given you 26 seconds. It's actually this. Remember, 1 ampule of magnesium sulfate is 2 ml. Okay, and this contains 1 gram magnesium sulfate. So if you remember, 14 grams is the total dose that we give. 4 grams we give loading dose IV, and the rest 10 grams we give IM as maintenance dose. And this 10 grams is divided into 5 and 5 in each buttock, right buttock and left buttock. Okay, yes, Abdul, you're right, it is B. Now, why 8 ml they're giving? Now, sorry, I just rubbed it. Okay, now 4 ml, this one sounded better. Initially, when you actually just look at the options, 4 ml will sound better, because you are confused between 4 gram and 4 ml. Don't get confused. This is not gram, it is ml. So when it comes to ml, it is actually 8 ml, because when you are having 2 ml, 1 gram, and if you want 4 grams, means it will become 8 ml. So you take 4 ampules and dilute it in 12 ml NS, because you have to make it 20%. So imagine 8 ml plus 12 ml will be 20 ml of the entire solution containing 4 grams of magnesium sulfate. So with your maths, you know it is 20% solution. Out of 20, only 4 gram is magnesium sulfate. So from 50% solution, initially it was 50%, 2 ml containing 1 gram. Now you have made it 20% solution. Okay. So the answer is 8 ml, or if they tell you 4 gram, if it is in grams, then it is 4 gram magnesium sulfate in 12 ml NS, because 4 gram will be 8 ml. Okay. I hope I'm clear. So the answer is B. 2 ml ampule has 1 gram magnesium sulfate. I just told you that is 50% solution. Pritchard regimen is loading dose 4 gram of 20% magnesium sulfate slow IV infusion. You make it 20% by adding 12 ml NS. So 8 plus 12 is 20. Okay. Load 4 ampules in 20 ml, add 12 ml. How fast you have to give it? You have to be slow. So minimum is 4 minutes and maximum you can go like 1 ml per minute. So you can take up to 20 minutes, but you don't have that much time. Patient is convulsing. You need to give the IV dose. So don't make it faster than 10 to 15 minutes. Okay. So sorry, minimum is 4 minutes and maximum you can go up to 20 minutes. So on an average 10 to 15 minutes you keep on injecting, and your assistants will keep on doing the other things, like take her bloods, send it to the lab, and the entire team will be working together. Somebody will be putting a catheter, somebody would be putting a mouth gag so she doesn't bite her tongue, and the frothy secretions have to be sucked out so that she doesn't aspirate. All these things will happen side by side. Okay. Total dose is 14 grams. Loading dose is given irrespective of the renal function. Very important. Don't get confused if they tell you the patient is under renal failure, her renal function is impaired. So will you give loading dose or not? Loading dose has to be given if she is convulsing. Okay. Hi, Dr. Devik. Maintenance dose is followed by, that is after 4 gram IV, you have to give her 10 grams of 50% magnesium sulfate. That means direct ampule you are taking. You are taking the direct ampule without any dilution. 5 gram means 5 ampules on this buttock and 5 ampules on the other buttock. Direct IM. Okay, it is given every 4 hours depending upon the magnesium levels in the body, and the toxicity has to be monitored. Dose is 5 grams of 50% magnesium sulfate IM in alternate buttocks, upper outer quadrant. The needle has to be 3 inches long because you want to go deep inside the buttock. You don't want it to just lie in the subcutaneous tissue. It has to be deep, and it has to begin till 24 hours after delivery, or till the 24 hours have happened after the last seizure. Hello, Dr. Vidya. Okay. Answer this question for me. Pregnant woman at 30 weeks is having painful bleeding PB and a history of decreased fetal movements with a high blood pressure. So what does that tell you? It's a PIH patient, and she's having APH also, and there is some problem with the baby also, and she's only 30 weeks. Very preterm. Okay. Per abdomen 34 weeks. So the gestational age was 30, but now she's 34 weeks. So I'm just helping you how to answer the question. So the fundal height is more than the gestational age. Contractions are present. Uterine tone is increased. What does that tell you? And the fetal heart is absent. Simple. What is it? Anybody? Can you tell me what is your diagnosis? PV, she is well in labor, active labor 6 centimeters, 70% effaced. Vertex is at -2, bag of membrane is forming. BOM is bag of membrane. Don't get confused. These are the short forms used by obstetricians in the labor room, and that is how they ask you the question. What should be the next step in management? First of all, you should know what is the patient. What patient is it? What is the diagnosis? It is PIH with what? Tell me. And then tell me the answer. Okay, KK. So I got your answer. Can you tell me the diagnosis also? Abruptio. Very good. So it's PIH plus abruptio. The baby is dead. So in a dead baby, why will you do a cesarean section? Why will you give her tocolysis? Why will you make the patient suffer? The baby is already dead. Why do you want the contractions to stop and you want the patient to carry on the pregnancy? And why will you do a cesarean? Okay, so antihypertensives and ARM. ARM is going to hasten the delivery. You know ARM is going to release prostaglandins, and it is a type of induction of labor. So you're trying to hasten the delivery. She's already 6 centimeters, so she will deliver very fast. Yes, Sanjay, it is B. Next question. All of the following are theories of causation of preeclampsia except. Now this is a very theoretical question. Dr. Ranjana might have covered it. It's total pathology, but you need to know this because this has been asked. Now, prostaglandins play an important role in preeclampsia. Thromboxane A2 is decreasing. Prostacyclin thromboxane ratio is increasing. So what they are asking in the first question is, since the denominator is decreasing, so the ratio is increasing. Is it true or false? They want you to tell the right answer. Endothelial dysfunction. Oh, sorry, except they want you to tell the false answer, the wrong answer. Okay. So don't miss this word. I missed it. Except. You have to tell what is wrong. Okay. Everything is true except. Endothelial cell dysfunction leads to reduced nitric oxide levels, and this causes the clinical presentation of preeclampsia. Vasoconstriction leads to ischemia, necrosis, hemorrhage, and organ damage seen in preeclampsia. Anti-angiogenic factors play an important role in preeclampsia. There is an increase in SFLT1 and decrease in PIGF, that is placental growth factor. It is PLGF. Tell me. It took me a long time to read the question. You must have now reached the conclusion as to what is the answer. What does thromboxane A2 do? TXA2 is a vasoconstrictor or a vasodilator? It is a vasoconstrictor. Prostacyclin, PGI2, that is the short form we use for prostacyclin. It is a vasodilator. Now tell me, in preeclampsia, what is going to increase? Right, KK. It is A. Thromboxane A2 has to increase. Placental growth factor is decreasing. SFLT1 is increasing. All the bad factors are increasing. Thromboxane A2 is increasing. SFLT1 is increasing. Endothelial cell dysfunction is the major dictum, which is basically destroying all the organs. Kidney, liver, eyes, all the end organ damage is because of the endothelial cell dysfunction. So all are true. Ischemia, necrosis. The only thing is this is the reverse. This is the answer. The reverse is true. It is actually decreasing. The ratio is decreasing because thromboxane A2, the denominator, is increasing. Prostacyclin is decreasing. Okay. So thromboxane A2 increases, prostacyclin decreases, ratio decreases. Etiopathogenesis includes all the vasoconstrictors are increasing. SFLT1 is soluble FMS like tyrosine kinase. Just mug it up. You should know what it is. Thromboxane A2 and serum endoglin are increasing. Dilators are decreasing. Placental growth factor, VEGF, are decreasing. Inflammation is happening all over the body. So cytokines, tumor necrosis factor, oxidative stress is increasing. Interleukins are increasing. Immunological intolerance. There is an intolerance between the maternal and the fetal tissues. That is why female who gets married to a second partner and she conceives again, even though it's not her first pregnancy, but she's exposed to the sperms of the partner, the second partner, the new partner. At that time, she can have preeclampsia again. It will be like a foreign body triggering the immune system and increase oxygen free radicals because of the oxidative stress. Okay, next question. Woman with 35 plus 5, so she is almost term, 36 weeks gestation, complains of epigastric pain, headache, blurring of vision. So again, this is a severe PET, blurring of vision is there. BP is quite high, 170, 110. She's having labor pains. Examination, she's almost in active labor, 3 centimeter dilated. Bag of Leica means bag of membrane is forming. What is the management here? Tell me. Let me put the timer on. Okay. Conservative management, administering tocolytics and delivering at 37 weeks. Treat hypertension, magnesium sulfate, consider termination. Okay. KK, you're answering A, C. Sohail, you're C. Give steroid cover and wait until steroid cover is complete. Okay, KK, you said C. A, you said for the previous question. So you both are correct. It is C. 36 weeks gestation, you don't need a steroid cover. She's fine. The baby is fine. You have to treat hypertension, yes. Administer magnesium sulfate and consider termination, because in termination, after termination only, you can basically help the patient come out of this problem. It's a defective placenta, so you have to terminate the pregnancy. So this is the answer, the proper answer. Tocolytics is of no use at 36 weeks, even if she is not having any preeclampsia or eclampsia. She is having preterm labor at 36 weeks. Go and deliver her. She's 3 centimeter dilated. Bag is forming. What will you have? What advantage will you have by reducing the contractions and delaying the pregnancy for another 1 week? Technically, 37 weeks is term. But if she is an established preterm labor at 36 weeks, you don't need to do anything. So conservative management, never. When she's a severe preeclamptic, hypertension, magnesium sulfate, stabilize the patient and then terminate the pregnancy. So there is no role of all this, and we have already discussed. Okay. Now, most commonly, now we are done with the PIH and magnesium sulfate. Now coming to most commonly seen in a 26-year-old female with intrauterine adhesions. What is that? Why have I kept this question? Because I got a lot of queries on this question, and the question can be changed in 2 forms. It can be either they can give you simply symptoms, dysmenorrhea, recurrent pregnancy loss, hypomenorrhea, oligomenorrhea, secondary amenorrhea. They may give you these options. Infertility. So what will be your answer here? What is the answer of this question and what is the answer of this question? Give me A, B, C, D and E and F. Okay. Answer the first question first. Most commonly seen in a 26-year-old female with Asherman syndrome. Sanjay, Abdul, C, C, B, Tarun, B. Okay. What will be the answer for this? What is the most common menstrual irregularity in Asherman syndrome? Hypomenorrhea, oligomenorrhea, dysmenorrhea, RPL, secondary amenorrhea. RPL is not menstrual irregularity. Okay, Stardust is saying C and A. You can answer just one, no? How can you say C and A? Okay, so you want to say that the most common menstrual irregularity in Asherman is A, hypomenorrhea. Anybody else? Okay, so the answer here is infertility. You are right. Somebody said C. Abdul, you said C. Sanjay, you said C. Here it will be secondary amenorrhea. Now, what is the difference between both the questions? One question is giving you only the symptoms. The second question is asking you out of menstrual irregularity, which is the most common, right? So if they give you, like for example, in this question, if they had asked you the most common complaint in a patient will be either infertility or RPL, recurrent pregnancy loss, or menstrual irregularity, in that case, you will say menstrual irregularity. So if it's a common group, they're asking you a common group of complaints, it is menstrual irregularity. But if they ask you specific symptoms, then it is infertility. Am I clear? If not, then tell me. If they ask you one particular subset, infertility, RPL, menstrual irregularity, it is menstrual irregularity for sure. Out of menstrual irregularity, it is secondary amenorrhea followed by hypomenorrhea, scanty menses, then oligomenorrhea, means delayed menses. But when it comes to typical symptoms, then it is infertility. Okay, so that is the reason why I took this question here. Sorry. Then Asherman syndrome, highest risk is excessive curettage. Most common cause is DNC in the postpartum period. You know that. Followed by DNC for missed abortion. So whenever you do a DNC in a patient who is either postpartum after delivery or after abortion, or you have done a packing, uterine packing. She just delivered and all the sinuses are open, the raw area is there, and you have done a packing at that time, you may cause Asherman syndrome. What are you writing, KK? Hypomenorrhea plus infertility both. Yes, hypomenorrhea is there, but when it comes to, it depends upon how they are framing the question. So the question that I told you here, infertility is the main complaint, that commonly seen thing. But in the menstrual irregularity, you will select secondary amenorrhea if it is there. If it is not there, then you select hypomenorrhea, means scanty menses. The latest AUB definitions from oligomenorrhea, hypomenorrhea, it has changed. Okay, so it will be scanty menses. Then the other causes of Asherman syndrome will be endometritis due to tuberculosis and schistosomiasis, TCRE, that is transcervical resection of endometrium, which is not done anymore, and any uterine surgery which can lead to adhesions. You have opened the uterine cavity, done a surgery on the endometrium, on the myometrium, myomectomy, metroplasty, cesarean. In that case, you may cause Asherman syndrome. Okay. Then, complaint of menstrual irregularity, as I told you, the most common, as a group, it is the most common symptom, followed by infertility, followed by recurrent pregnancy loss. So when it is a group, then the first will be menstrual irregularity, second will be infertility, and third will be recurrent pregnancy loss. Among menstrual irregularity, it is secondary amenorrhea, followed by scanty menses, followed by delayed menses. Okay. If the choice is secondary amenorrhea, hypomenorrhea, oligomenorrhea, and infertility, the answer is infertility. We are done with it. That is all I want you to know about Asherman syndrome. Okay, coming to this question now. Now we're coming to endometrial hyperplasia and endometrial cancer, starting with genital cancers. 50-year-old lady came with abnormal bleeding per vaginum and an enlarged uterus. So she is 50, menopausal, perimenopausal, abnormal bleeding, postmenopausal bleeding, enlarged big uterus. Big uterus means you're kind of ruling out cervical cancer. You're kind of going towards endometrial hyperplasia, or maybe a fibroid, or maybe an endometrial cancer. Okay, so you have some uterine pathology. Which of the following is the most suitable diagnosis? Remember, most suitable diagnosis, first line diagnosis, different things they will ask. First line diagnostic tool, then most suitable diagnostic test, or you can say the next step of management. All these things are very, very confusing. So what will be your answer? Natasha is saying B, Abdul is saying D, KK is saying C. Okay. So let me answer this. This CT and MRI are very, very costly procedures, right? So when will you do CT and MRI? MRI is generally done for soft tissue delineation. You have to remember these, students. MRI is basically to delineate between uterine sarcoma, uterine fibroid, adenomyosis. So whenever there's a soft tissue problem which sonography cannot pick up, you do MRI. It's costly. CT scan is also costly. CT scan is done when you want to establish that yes, you know it is a cancerous case. You want to see how much it has how much it has spread, whether the lymph nodes are involved or not. So CT and MRI are basically done when there is a difference in the diagnosis, the biopsy and the sonography. You're not able to reach the conclusion, or you have to stage the cancer. Initially, we used to do the staging, laparotomy. Now CT scans, PET scans, MRIs are helping us. So this will not be the most suitable diagnostic criteria. Okay. So the answer here will be, it is not TVS, Tarun. If you say TVS, it will be the next step of management. Yes, the next step of management will be TVS, but the most suitable diagnostic test will be hysteroscopy, because in hysteroscopy we can do a biopsy, we can visualize whether it's a focal growth, whether there is some other pathology, there is a polyp hanging, there is a fibroid hanging which was not diagnosed in ultrasound. But yes, the first line investigation or the next step of management will be TVS, but the most suitable diagnostic thing, that is what they are asking, the most appropriate diagnostic investigation will be hysteroscopy, because it has so many advantages. It can be diagnostic, it can be therapeutic, you can do a biopsy, you can do a fractional curettage, you can do everything. Okay. So postmenopausal bleeding, abnormal bleeding means she is postmenopausal or perimenopausal, enlarged uterus. So this is how you approach the question. So you've done this all. We don't need to repeat this, solving each response to get the best result. Now, staging of endometrial cancer. Quickly recapitulating, this might come as a question, a proper direct question. They might give you that this is the spread of the cancer and what is the stage. Okay. Stage 1 will be confined to the uterine corpus. So this is the uterus. And if the cancer, if this is the myometrium here, this is the myometrium. So they will tell you where the cancer is. Okay. So the cancer, if it is lying in half of the myometrium, only this much of the cancer is occupying the myometrium, then that means stage 1A. 1B will be occupying more than 50% of the myometrium. So that will be stage 1B. 2 is invading the cervical stroma. That means it has become a cervical cancer now. Stage 3 is regional or local spread, right? And stage 3A will be uterine serosa. And stage 3B will be just near the uterus in the parametrium or in the vagina. Now, how do you manage? Why am I putting management in between? I'm not completing the staging because I want you to understand the stage and the stage-wise management. Because once we go towards the 4th stage and we come back to stage 1 in the management, you will forget. It's very confusing. Okay. So the management options in endometrial cancer, remember, there is a contraceptive 50% reduction with the OCPs. Anything which reduces the thickness of the endometrium will reduce the chances of endometrial cancer. Like for example, smoking. Smoking is also reducing the thickness of the endometrium because it decreases estrogen level. It decreases estradiol. So smoking is a protective factor for endometrial cancer, but it is not a protective factor. It is a high risk factor for cervical cancer. Okay. So contraception and Mirena coil are protective for endometrial cancer because it is reducing the thickness of the endometrium. Anything which is reducing the estrogen level. Now, the modalities, treatment modalities which we normally discuss are surgery and radiotherapy. Chemotherapy also, because if it is a very old patient with comorbidities, you will avoid surgery and radiotherapy. You may give her chemotherapy. And the chemotherapy is the same what we use in ovarian cancer. Cisplatin, carboplatin, paclitaxel, Taxol, adriamycin. So you don't need to mug up because it's all very simple. It just keeps on repeating. Okay. So these are the 3 modalities. Combined therapy, yes, CCRT can be given. That is combined chemotherapy and radiotherapy, CCRT. Okay. Hormonal therapy, I will put a big question mark because I haven't seen any questions on that. No direct questions on hormonal therapy because it is something which the oncologist will know. It is above your level. So you don't need to know whether the progesterone receptors are present or not. The pathologist will tell you in the biopsy that, okay, these immunofactors are there, immunostaining is there. So you can give tamoxifen, you can give progesterone. So this is not a question expected. So you have to stick to surgery, radiotherapy plus minus chemotherapy. Now, stage 1, grade 1. And 2. Grade 1 and 2. Grade 1 and 2 means it is either a well differentiated or moderately differentiated. We are not talking about the poorly differentiated grade 3. Grade 3 is poorly differentiated. So stage 1A, less than 50% of the myometrium, but it is less than 2 centimeter, then it is only simple hysterectomy. When it is more than 2 centimeter, we do a pelvic lymph node dissection. So this 2 centimeter demarcation is not there in the staging, but it is there in the management. Remember this. Stage 1B, more than 50% of the myometrium involved. Same. Because it is more than 50%, now radiotherapy will step in. So radiotherapy is stepping in as soon as stage 1B is happening, is more than 50% of the myometrium involvement. Remember this. Radiotherapy, no radiotherapy till stage 1A in endometrial cancer. Stage 1A, after that 1B, you start with radiotherapy. But depending upon the size of the tumor, if it is less than 2, no lymph node dissection. More than 2, you do a pelvic lymph node dissection. Now, you all know the uterus will drain into internal iliac lymph nodes, then external iliac lymph nodes, and then the common iliac, and then the para-aortic. So this is the sequence how it goes. The internal iliac, then the external iliac, then the common iliac, and then the para-aortic. So this is how the sequence goes. Okay. So you should know as to what dissection has to be done. In stage 2, when it has reached the cervix, it will be Wertheim's. Either type 2 or type 3. You should know what is type 2 to what is type 3. I'm not going to the details. If you want to me to remember, you want me to like explain this to you, I will come to that slide. If you want me to skip it, I'll skip it. Now, pelvic and para-aortic lymph node dissection is done in stage 2. Why para-aortic? Because now it is spreading to the cervix and it is an advanced stage carcinoma. So it is not just pelvic. We are going to pelvic, para-aortic also, plus RTH also, radiotherapy also. Hello, Dr. Abhinami. Okay. Coming to stage 3. Now, 3A and 3B we have done. 3A is invading the uterine serosa till here. And 3B is vagina and parametrium. What is 3C? 3C is metastasis to the lymph nodes. So metastasis to the lymph nodes, this is pelvic and this is para-aortic. C2, C1 and C2. 4 is very simple, just like cervical cancer. Bladder bowel mucosa is 4A and 4B will be intra-abdominal liver and inguinal lymph nodes and all. Okay. Now, how do we manage stage 3 and stage 4? Stage 3, whether it's grade 1 and 2, everywhere it is grade 1 and 2. So far, we are not talking about grade 3. Grade 3 will become, all grade 3 tumors will come in one nutshell. All grade 3 tumors will be poorly differentiated. So they will all come in one nutshell where you will add chemotherapy, radiotherapy. Surgery will be stage wise depending upon whether it's stage 1A, it's stage 1B. So TH, BSO in stage 1, stage 2 is Wertheim's, stage 3 onwards it becomes radical. So that will depend upon the stage. But if it is grade 3, you have to give radiotherapy, you have to do pelvic lymph node dissection, you have to do para-aortic lymph node dissection, and you have to give plus minus chemotherapy. Okay, stage 4 will be obviously debulking because now we cannot remove the entire tumor, it is spread everywhere. Okay, and stage 3 is Verdheim's type 2 or type 3 plus all those para-aortic and lymph node dissection and radiotherapy. So very simple. Still stage 1 there is no radiotherapy. Stage 1B onwards we do radiotherapy. Stage 1A no radiotherapy. Stage 1A less than 2 centimeter no pelvic lymph node dissection. Stage 1B also less than 2 centimeter no lymph node dissection. Okay. Now remember, this is a very important question. All type 2 tumors. You know, endometrial cancer has been divided pathologically into adenosquamous, endometrioid, papillary, clear cell. But there is another definition or another division of endometrial cancer into type 1 and type 2. What are these? Type 1 are the ones with good prognosis. I'll come to that table. Type 2 are the ones which are happening in the postmenopausal age group, which are not estrogen dependent, and they have a very high malignant potential. And they will include which ones? They will include clear cell carcinoma, papillary carcinoma, all the type 3 not the type 3, the grade 3 carcinomas, they will all be included in the type 2. So whenever the question says it's a clear cell carcinoma, papillary carcinoma, or a very poorly differentiated carcinoma, it will fall into this category. So again, you will do a stage-wise surgery depending upon stage 1A, 1B, stage 2, stage 3. But you will not miss lymph node dissection, both pelvic and para-aortic. You will not miss chemotherapy, radiotherapy, plus you will not miss omentectomy and peritoneal washings. Peritoneal washings, biopsy. Okay, just like ovarian carcinoma, because these papillary, clear cell, endometrial carcinomas, they will spread through the peritoneum. So omentectomy and peritoneal washings have to be done in all type 2 tumors. Okay, now lymph node dissection, as I told you, is done only in all type 2 varieties when it is a high risk one, or 1A grade 3 of type 1 variety means it's a grade 3, any type of grade 3 variety. Stage 1A only if it is tumor size is more than 2 centimeter. Stage 1B when it is more than 2 centimeter. So this we just did in this table. Don't get confused. I've just recapitulated it, just rewritten it. So basically, lymph node dissection is done only when the tumor is more than 2 centimeter in cases of stage 1. After that, lymph node dissection is done in all grade 3 tumors, and in all type 2 tumors we do a lymph node dissection. RTH is not required till stage 1A if it is grade 1 and 2. If it is grade 3, poorly differentiated, you have to give everything, do everything. Okay. Then coming to types of endometrial carcinoma depending upon how they behave. So that is type 1 and type 2, very important. Type 1 is having a good prognosis. So the unopposed estrogen, the estrogen dependence will be there. It will be perimenopause, not postmenopause. It will be dependent on the estrogen. It will be well differentiated, minimal invasion. These are all endometrioid and adenocarcinomas grade 1 and 2. It will not be a poorly differentiated one. It will not be papillary clear cell. It will be simply endometrial adenocarcinoma. And the patient will be obese, generally seen in white races, polyploid because of excess of estrogen. There will be no expression of these bad genes P53, HER2 and new overexpression. No, it will only be P10 mutation which will be seen, which has a good prognosis. Okay, so the P10 mutation is good for endometrial cancer. Remember, P10 mutation is a gatekeeper gene. The gatekeeper gene for endometrial cancer is P10 because it has a good prognosis. It is just the opposite in type 2. So this is not favorable. These are present, but this is absent. Aneuploid, black females, postmenopause, no estrogen dependence, poor differentiation, deep invasion, papillary, serous, clear cell, all grade 3 adenocarcinomas, and these are thin patients. So these will require excessive radiotherapy, chemotherapy, surgery, omentectomy, everything will be required in type 2 tumors. Okay. Hi, Rajni. Okay. 70-year-old female, answer this for me. Now you know the staging and now you know the how you manage it also. 70-year-old woman presents with endometrial cancer that has spread to the lymph nodes. What is the most appropriate treatment? So a 70-year-old woman with endometrial cancer has spread to the lymph nodes. Tell me the answer. Surgery, radiotherapy, chemotherapy, hormone therapy. It's a very incomplete question. The stem of the question is also incomplete. The options are also very incomplete because you will not just do one, you will combine them together. But what they want you to understand is it's an old lady with a extensive cancer which has spread to the lymph nodes. What will you do? Thank you, Abdul. It is C. It is chemotherapy. Surgery. The best answer would be what? The best answer would be surgery if she doesn't have any comorbidities like debulking surgery. It can be debulking, right? Plus chemotherapy, plus minus radiotherapy. Now, because she's old, they want you to understand that radiation therapy is going to have a lot of side effects. Then surgery again may not be possible. It will be extensive surgery in cases where it has spread to the pelvic lymph nodes. So the first thing we do is a neoadjuvant chemotherapy. adjuvant chemotherapy. That means before surgery, we try to reduce the size, or sometimes just chemotherapy, palliative treatment. Yes, thank you, Abhirami. It is C. Now, approaches, age not very appropriate for surgery. Lymph node spread 3C stage. It is a 3C stage. Okay. Advanced stage, it will need exenterative surgery. Old age plus lymph node involvement, poor prognosis, and most appropriate. The lead is asking you what is the most appropriate treatment. That is how we approach the question. So again, the same thing. Radiotherapy, they are quite sensitive, but side effects are more. Chemotherapy is best option, and that is Taxol, Adriamycin, Paclitaxel, that is TAP. Right? Hormone therapy, there is no mention whether the cancer is hormone dependent or not. We don't know. So I told you, just don't mention hormone therapy in endometrial cancer. Stick to radiotherapy, surgery, and chemotherapy. Now, 55-year-old lady, postmenopausal woman, presents with abnormal uterine bleeding. Okay. Endometrial biopsy is showing endometrial carcinoma with hobnail cells with grade 1 differentiation. MRI was suggestive of stage 1A. Now, you know it is an early carcinoma, stage 1A. It is grade 1, which is very good prognosis, but there is hobnail cell. What do you mean by hobnail cell? What does it indicate? What kind of cancer it is? You must have read in pathology. Tell me, what should be the appropriate kind of surgery here? What kind of tumor is it? Hobnail cell. Waiting for your answer. Somebody? Okay, waiting for your answer. No answers? Hobnail cells are seen in clear cell carcinoma. I just told you clear cell carcinoma is a type of type 2 tumor. So now type 2 tumor, you will do radiotherapy, you will do chemotherapy, you will do a pelvic and para-aortic lymph node dissection. Yes. Plus you will do omentectomy and peritoneal washings, just like ovarian cancer. But because it is stage 1 with grade 1 differentiation, you will simply go for a TAH and BSO. Okay, so you don't need to go for Bardheims or exenterative surgery. So the answer will be, Natasha is saying TAH with BSO, omentectomy, peritoneal biopsy, because this is what I just told you. But there is a difference between lymph node sampling and lymph node dissection. What will you choose? So definitely this is wrong. This is wrong. Now what is the right answer here? They're almost the same. One is saying sampling, one is saying dissection. What will you do here? Sohail, Sonali, okay, Shimona. Hi Shimona, hi Wondergate. Okay, no. A and B are wrong. It is actually a stage 1 carcinoma, stage 1A, that is less than 50% of the myometrium involved. So I told you in stage 1A, we don't do lymph node dissection if it is less than 2 cm. But because it is type 2 tumor, we are doing that. But in this case, we will not do a dissection, we will do a sampling. So this is the correct answer. C is the correct answer. Why to subject her for dissection? Don't remove the entire pelvic and para-aortic lymph nodes. Do a sampling. Because it's a type 2 tumor, because you know the biopsy has come back as clear cell carcinoma. Do sampling. While doing surgery, you will see some lymph nodes popping up. They might be enlarged. Do that sampling. If you can't see any popping up lymph nodes, enlarged lymph node, then you just go to the pelvic lymph node, the most commonly involved, the internal iliac. If that comes back positive, then you can give her radiotherapy or chemotherapy. Okay? It's all right, Natasha. You can always answer the next question. Hobnail cells are found in clear cell carcinoma, which is rare, very aggressive. Grade 1 does not need extensive surgery. So it is TH, BSO, stage 1A, early carcinoma, restricted to the uterus, less than 50% of the myometrium involved. This option is correct for normal endometrioid carcinoma. Now, this we have already discussed. Let us not solve each and every response. So if it was an endometrioid carcinoma, adenocarcinoma, then the option would have been TH, BSO, right? Because it is grade 1, differentiation stage 1. Stage 1A, less than 50% of the myometrium is involved. So, because they haven't mentioned whether it is less than 2 cm, more than 2 cm. If it was mentioned less than 2, more than 2, then you would have been confused whether we do lymph node or not. So, if it is less than 2 cm, endometrioid, I'm talking about endometrioid. I'm just changing the question. Remember, if it is endometrioid or adenocarcinoma, less than 2 cm, the option is this. If it is again endometrioid carcinoma, but more than 2 cm, you do a lymph node dissection. But because this is type 2 tumor, so you're going for omentectomy, peritoneal biopsy with lymph node sampling because it is early carcinoma. If it was advanced, stage 2, cervical, cervix has been involved, then it would have been lymph node dissection. I hope that is clear. Now, coming to the next question, 50-year-old woman presents with postmenopausal bleeding, thickened endometrium on transvaginal ultrasound. endometrial biopsy shows a poorly differentiated grade 3 tumor, grade 3 endometrial cancer, and that is endometrioid, that is type 1. Type 1 is endometrioid or adenocarcinoma. CT shows no evidence of metastasis. So it's an early cancer, but it is poorly differentiated. So the main dictum will lie on this. It is early carcinoma, it is type 1 because it is endometrioid adenocarcinoma, but it is a grade 3. Okay. So what is the appropriate management? What will you do now? Come on, tell me. Total abdominal hysterectomy, bilateral salping oophorectomy, that is TAH, BSO, just to confuse you, TAH with BSO, with omentectomy peritoneal biopsy. That is done in type 2, not type 1. TAH, BSO with lymph node dissection. TAH, BSO with lymph node dissection plus minus radiotherapy. Lymph node dissection plus minus chemotherapy. What will you do? Had it been a grade 1 or grade 2, not a poorly differentiated grade 3, we would have selected, there is no evidence of metastasis. In that case, we would have just done maybe TAH, BSO with lymph node dissection or sampling or simply radiotherapy, depending it's 1B or 1A. The stem of the question is not very clear. So what will you do? No starters. It is not omentectomy and peritoneal biopsy. It is not a type 2 tumor. It's a type 1 tumor. In type 1 tumor, you go with the stage-wise management. All grade 3 tumors, whether it's type 1 or type 2, you have to go with lymph node dissection. You have to do a radiotherapy. So the answer is this one. It is not this. It is not this. It is not this. It is C. Yes, Abdul, it is C. Okay. Because it is adenocarcinoma. Adenocarcinoma falls in the type 1 category. The main point here is grade 3. This is going to change everything. So type 2 tumor, you do omental biopsy, you do peritoneal washing, you do radiotherapy, lymph node dissection, everything. In grade 3, omental biopsy, peritoneal washing not required, but radiotherapy, chemotherapy and lymph node dissection very, very important. So that is how you do this. Okay. THBSO, why? Because it is not a metastatic cancer, so you are not doing Vardheims or radical hysterectomy. Right? I hope it's clear now, because now I'm moving on to the next topic, molar pregnancy, GTN, choriocarcinoma. Okay. Now, a 35-year-old woman with a complete molar pregnancy presents with HCG level of 2 lakhs international units per ml, very high HCG level. What will be the next appropriate management? You'll give her chemotherapy, you'll do a hysterectomy on a 35-year-old patient, you'll do a repeat curettage, or you will just simply observe. Tell me. Come on, I'm waiting. What are the options here? I mean, what is the best option here for you? A. Okay. C. No, I would go with A. What are the indications of chemotherapy? Very high HCG level, or there is a TLC, that is theca lutein cyst, more than 6 centimeter, and there are other other indications also. So methotrexate chemotherapy, she already has had a DNC. That is why we know it's a complete molar pregnancy, right? DNC has been done. She's not bleeding. They have not mentioned she's bleeding, so we will not do a repeat curettage. No, we will go for methotrexate chemotherapy, because you may do a repeat curettage. The best answer would be you do a HCG level, which has already been done. You do a TVS also. You may do a repeat curettage if required, if you see that there is a lot of thickness inside, and then you give a methotrexate. That has to be given. This has to be the option. Okay. Best option would have been a combination. Hysterectomy, no. Observation, not at all. 2 lakh HCG, no. So you have to give a methotrexate chemotherapy. So high levels of HCG, lead is most appropriate treatment after 1 suction evacuation. Patients with high risk gestation trophoblastic neoplasia, when the HCG is more than 1 lakh, they have to be treated with chemotherapy. Now, whether it's a single agent or a multi-agent, that will depend upon whether it's a high risk or a low risk. But that is basically when we diagnose choriocarcinoma. In choriocarcinoma, we decide whether it has to be IMACO regimen, multi-drug, or a single regimen depending upon the WHO scoring. If it is 6 or less than 6, it is single agent. If it is more than 7, then it is the high risk one. But we are talking here about the complete molar pregnancy. It is not a choriocarcinoma. Hysterectomy not recommended. Repeat curettage, no use. Okay. Then, remember the indications of hysterectomy and remember the indications of chemotherapy. Indications for hysterectomy here will be women more than 40, family is complete, lesion is confined to the uterus. Okay. So, women who are more than 40, they are having this problem, persistent molar pregnancy, or there is excessively high HCG level, or she's bleeding, and then we are repeating the curettage. Why? She has completed her family, do a hysterectomy. PSTT, we know PSTT is what? Placental site trophoblastic tumor, or ETT, epithelioid trophoblastic tumor. Even invasive mole. In invasive mole also, the option is hysterectomy. Okay. Intractable vaginal bleeding. Localized uterine lesion when the stage 1 GTN is resistant to chemotherapy. So either her family is complete, or it's a typical this type of tumor, or there is too much bleeding, or when there is resistance to chemotherapy, or you have perforated the uterus accidentally during curettage and there is an invasive mole. Okay, so these are the indications for hysterectomy. Chemotherapy is indicated when the initial level of HCG is either very high or it is plateauing. So in this case, it was high, very high. Bilateral thecal uterine cyst is more than 6 centimeter. Age more than 35, you will go for chemotherapy, but that doesn't say that if she is 25 and she is having all the other risk factors, you will not give a chemotherapy. Then evidence of metastasis irrespective of the level of HCG. Initial large size of the uterus. Women cannot come for follow-up. You know that this patient is not going to come for follow-up. Okay. Now, IUCD is the best contraceptive. Well, IUCD, yes, initially IUCD was said to not to be used, but I would say barrier contraceptives are the best, although they do have a very high failure rate. But yes, IUCD has been recommended now. In fact, after 6 months after the follow-up, once the HCG is below 5, she can even go for OCPs. IUCD is better to avoid initially when she is having irregular bleeding, because that can lead to false diagnosis of continuous bleeding or irregular bleeding. Okay. Now, women cannot come for follow-up. Initial large size of uterus, high HCG, evidence of metastasis, and high risk of choriocarcinoma. The risk factors are very young or above 40, multipara who refuses hysterectomy. These are the indications for chemotherapy in GTN. Now, answer this question for me. 23-year-old lady had complaints of persistent vaginal bleeding after a complete molar pregnancy. Now, initially in the first question, it was the HCG level was very high. Now she's having persistent bleeding. What will you do? You will do a hysterectomy? No way. At 23 years, I'm just crossing the options which are absolutely not required. Observation, no way, she's bleeding. So what is your answer? Chemotherapy or repeat curettage? Slightly different question, and I'm sure you'll be able to answer this. 23-year-old very young lady, persistent bleeding even after 1 DNC because the diagnosis is complete molar pregnancy. What will you do? Will you give her chemotherapy? You may. They haven't told you the beta HCG level. But what will be the first option? The first option will be repeat curettage. Yes, Abdul, very, very right. It is repeat curettage in this case. Okay. So the best option here will be do a beta HCG, do a TVS followed by repeat curettage if required, and you may give her chemotherapy also. But she's very young. So indication of chemotherapy is generally after 35 years. Okay. Complete molar pregnancy has a risk of developing persistent GTN. That is the reason why we don't leave it. 15% risk of developing a persistent GTN. So we have to treat it and we have to see that the HCG levels come back to less than 5. And the lead will be the next step of management. The lead question, the stem of the question, that is very, very important. Now, this we have already discussed. Next question, 30-year-old woman with a partial molar pregnancy. Partial molar pregnancy means the baby is visible. Some parts of the baby are visible. Okay, it has been treated with suction and curettage. What is the appropriate follow-up protocol for this patient? So the patient has had DNC. It came back at partial mole. Partial molar pregnancy will mimic like, it will look like a missed miscarriage because the baby will be seen and there will be some vesicular growths there, placental growths will be there. So the answer, what I'm getting, Ashutosh is saying B, Stardust is saying B. Okay. Anybody else? Definitely you will not do a single measurement. You will not leave it that you will not do HCG measurement. No, the answer is A. You have to do it every month. Why do you want to do it every week? It is not a complete mole. It is a partial mole. It has a very low malignant potential. It has a very low incidence of becoming persistent. So you go for A. HCG measurement every month till the HCG comes back to normal. That is how they confuse you. Both the stems are so similar. So approach to this question is that the young patient is there. So you will obviously think about not chemotherapy, although the option is not there. Partial mole has low malignant potential. So explanation is after treatment of partial molar pregnancy, the patient should have monthly HCG levels till it returns back to normal. This is because there is a risk of developing persistent GTN and the HCG levels are a useful marker for monitoring to detect these problems. Let us quickly recapitulate what we have read before and you can just tick, tick, tick with me. Go very fast that yes, you know this. Karyotyping here it is triploidy. Partial mode is one sperm plus egg. And this egg is not inactive, it is active. Remember. So it is a triploidy. Okay. So it can be 69 XXY. One X is from the mother. This X is from the mother. Other two sperms can be 1X, 1Y. Both can be X or both can be Y. So these can be the three types of chromosomal structures in partial mode. Now, triploidy and diploidy, you know what it is. Diploidy means this is just one sperm plus empty egg. This is inactive. So yes, egg has been fertilized, but this is inactive. So we are not considering this egg at all. So it is one sperm plus one sperm, which is monospermic and dispermic. What do you mean by that? This is always diandry, and dispermic means there are two sperms. In complete mole, one sperm generally duplicates. It becomes monospermic. One sperm generally duplicates and gives rise to its brother. Okay. So this becomes double because it is duplicating. So it is generally monospermic, but it can be dispermic like partial mole. So difference between dispermy, monospermy means how many sperms are fertilizing the egg. Difference between diandry and monoandry. This is diandry. Okay. And this is monospermic and dispermic. Androgenesis means entire genetic material is paternal. That is the difference. Androgenesis, you need to know, is seen only in complete mole. It is not seen in partial mole. So diandry, monospermy, dispermy is just the same. Monospermy means one sperm. Dispermy or diandry means two sperms. In triploidy, there are two sperms plus one egg. So there is triploidy of the triple genetic material. In complete mole, it is just the sperm which is either duplicating or two sperms are fertilizing an empty egg. Okay. Thank you, Akshat. Histopathology. Hydropic degeneration is less. Obviously, everything is less in partial mole. Some fetal parts are seen, so it looks like a missed abortion. Some blood vessels are also seen because the maternal genome is active. Trophoblastic scalloping is seen. Inclusion bodies are seen. Everything is present. In molar pregnancy, sorry, just in the camera. Okay. In molar pregnancy, hydropic degeneration will be more. It will be highly differentiated. Syncytial trophoblastic marked diffuse proliferation will be there. Here it will be simply focal proliferation. So you will see the baby also, and you will see some focal proliferation of the placental tissue also. There will be no fetal parts, no blood vessels. Scalloping will be absent. Inclusion bodies will be absent. And there is one more thing which is absent here, that is immunostaining with P57 KIP2. That is something you need to memorize. This question has already come. Immunostaining with P57 KIP2 is basically a pathology thing. It is a pathology. Pathologists will tell you whether the staining is positive. It is positive because it is the maternal genome which is causing this to become positive. In complete mole, it is absent because the maternal genome is inactive. So scalloping is not there in complete mole. Immunostaining with P57 is absent, and there is no inclusion body also. These are the differences. Okay. Then what else? Theca lutein cyst will be absent in partial mole because the HCG level is low. The TVS will resemble a missed abortion because you can see the baby also, and you can see some placental hydropic degeneration also combined together. 3 to 5% chances of GTN here. Here it is 15 to 20% chances of GTN. 4% can become choriocarcinoma. Here only less than 1% can become choriocarcinoma. So HCG has to be monitored monthly, not weekly. Okay. Monthly monitoring is enough in partial mole. In complete mole, it is a snowstorm appearance. We know that snowstorm appearance. Dr. Abhishek will cover it in sonography findings. That live session is due. It will be happening very soon. Levels of HCG will be high. Theca lutein cyst will be present because they mimic LH and they will cause excessive proliferation of the theca cells of the ovary. Sorry for the camera. It's just kind of sliding again and again. All right. Okay. So immunostaining will be negative here because it's an empty ova. Right. Easy to remember. Everything is present in partial mole. Everything is absent in complete mole. It is a triploidy. It is a diploidy. Okay. 80% of the H moles resolve with treatment. 15% will persist as invasive, persistent or residual mole. 5% will develop into choriocarcinoma. So 4% to 5% will develop into choriocarcinoma. 85% will resolve on their own, but 15% may become invasive. They may become like an invasive, locally invasive or persistent mole. What can happen? Complications in complete mole? Tell me. Complication will be PIH again because continuous proliferation of the placenta, because we know it's a defective placenta which leads to PIH. So in mole, because it is a placental proliferation, it's a placental tumor which is happening. So PIH can happen even before 20 weeks. Then excessive HCG will lead to hyperemesis gravidarum, thyrotoxicosis because it can mimic TSH also, it can mimic LH also. Okay, and respiratory distress because these vesicles can escape into the venous circulation of the pulmonary circulation. It can enter the veins, the sinuses, and it can lead to PE. Then suction evacuation is the gold standard. They will ask you what is the gold standard treatment, that is suction and evacuation, followed by prophylactic chemotherapy in selected cases, routinely not required, 80 to 95% regress after dilatation and evacuation. Partial mole, only suction evacuation is necessary. chemotherapy is not needed. Remember, very important, in partial mole, if in the question they had asked you chemotherapy option, you will not take that. Okay, you can do an HCG level measurement every month so that you know that it is regressing, but you don't need to give chemotherapy because the malignant potential and the potential of persisting is very, very low. Chemotherapy methotrexate in a molar pregnancy is given only once a day. Oh, sorry, it is given only for 1 day, and it is 5 times a day. It has to be repeated 7 to 10 days, 3 courses. So, for example, 1st April, you are given 5 doses in 1 day. Then you call her again on 8th April, and then you call her again on 15th April. So, every 7 days you are calling her for 3 courses. Total 3 courses in complete mole. Why I am writing this? Because it is slightly different in the choriocarcinoma regimen. Now, answer this question for me. A 26-year-old, yes, the alpha subunit. You're right. The beta subunit is different. The alpha subunit is common. That is why we do a beta HCG whenever we have to check for any particular hormone which are kind of similar. HCG, LS, we do the beta subunit so that we know that we are checking the right hormone. 26-year-old lady with mild bleeding per vaginum, 10 weeks history of amenorrhea. So 2.5 months pregnant. Pregnancy test positive. Ultrasound shows fetus. No heartbeat. Placental mass with cystic areas. Till now we know it's a partial mole of 2.5 months pregnancy. HCG level was higher than as compared to the normal at that gestation. Again confirms molar pregnancy. She underwent suction and evacuation, which is the gold standard treatment. Products of conception was seen and sent for histopathology. What can you expect? Can you expect area stellar reaction? Can you expect absence of villi? Absence of villi are seen where? They are seen in, tell me, I'm not writing this. Retained products of conception will you see without any hydropic changes, or you will see hydropic degeneration with immunostaining and P57. Very good, Ashutosh. It is hydropic degeneration with immunostaining P57 KIP2 positive. I just told you because in partial mole the maternal genome is inducing this hormone, this enzyme, and that is why it is showing a staining positive. Area stellar is seen in ectopic because the pregnancy is not in the uterus, but because of the progesterone and HCG, there are some changes in the endometrium. Absence of villi is seen in choriocarcinoma. It is not a case of choriocarcinoma. Retained products of conception with no hydropic changes is a normal pregnancy. Normal missed abortion. They have already told you it is a partial mole. You can easily make out from the question it's a partial mole. So the answer is hydropic degeneration with immunostaining positive. Okay, we have done this. Now we've already done and discussed this. Okay. Then coming to recap of the theory, GTN. The most common GTN which develops after molar pregnancy is invasive mole. Remember, it is not choriocarcinoma. The most common neoplasia which can develop after a complete mole is invasive mole. The most common GTN which develops after normal delivery is choriocarcinoma. But retrospectively, mostly the choriocarcinoma will develop after molar pregnancy. So most of the molar pregnancies, if they ask you what is the most common neoplasia which develops after molar pregnancy, is actually invasive mole. But retrospectively, if you see a choriocarcinoma, she will have an antecedent pregnancy which was a molar pregnancy. But if a normal delivery patient has to develop a choriocarcinoma or a GTN, it will be choriocarcinoma or PSTT. Okay, understood the difference? PSTT most commonly develops after full term pregnancy. So the most common GTN after normal delivery is choriocarcinoma. That is number 1, and the second one is PSTT. But generally, it is after the molar pregnancy which develops into choriocarcinoma. Hi, Isha. Okay, age of the female. The risk factors for developing a GTN, that is gestational trophoblastic neoplasia, is age of the female more than 40, beta HCG more than 1 lakh, uterine size larger than the gestational age, bilateral theca lutein cyst more than 6 centimeters. These are all the indications which we read in indications of chemotherapy also. So these are the risk factors when the molar pregnancy can develop into GTN. It can be choriocarcinoma, it can be invasive mole, it can be PSTT. So these are the risk factors, and that is why these are the risk factors for chemotherapy also, the indications for chemotherapy also. And there is a slow decline, either the beta HCG is plateauing or it is increasing. Okay, so that is how we come to know that these are the risk factors and this patient needs chemotherapy. What are the lab criteria? Very important. I would label it as very important because I have seen these questions coming, although I have not been able to pick up that question for you here. Now, what are the lab criteria after molar pregnancy, after evacuation for the diagnosis of GTN? So these are the risk factors. But what are the factors, the lab criteria which will tell you, okay, she's developing GTN? One is you do a histopathological examination of the tissue and it comes back as GTN. Okay, that is confirmatory. But what are the other things? Either you do a HCG value, 4 consecutive HCG values at day 1, 7, 14 and 21. So for 4 weeks, every week you did a HCG value and it was either showing a plateauing or less than 10% decrease. So either it is showing like this, it is increasing, or it is decreasing, or it is just simply plateauing. So less than 10% decrease. Or you did a 3 consecutive values of HCG, day 1, 7 and 14, and there is more than 10% increase in the previous value. So either increasing like this, or it is plateauing here, or it is decreasing, less than 10% decrease. Beta HCG remains above normal even after 6 months. So either it is showing an increasing trend, or it is showing a plateauing, or even if it's decreasing, it is very, very less decrease, almost a flat line, or even if it is showing a decrease, but even after 6 months, you're continuously monitoring her. It is not coming back to normal. It is not coming back to less than 5. That means she is developing GTM. Okay. Choriocarcinoma locally invasive as well as it can metastasize. Now, choriocarcinoma is the only GTN, gestational trophoblastic neoplasia, which can metastasize to the entire body. It can go to brain, lungs, liver, spleen, everywhere. Vagina also. Most common route of metastasis here is hematogenous. The most common site is lungs in 80%. Vagina is only 30%, and that is suburethral, that is just below the urethral opening, and pelvis can be 20%. Vaginal metastasis is seen in stage 2. There is a question on staging also. Ashutosh, yes, it should be done weekly. In molar pregnancies, complete mole, because if they are high risk, then it has to be done weekly. If it is a partial mole, it has to be done monthly. That is the reason why they have written this weekly. Day 1, day 7, day 14, day 21, day 1, 7, 14. So this is how they monitor a complete mole pregnancy, especially if it's a high risk one. Okay, high risk because she's age is more than 40, HCG is high, TLC is high, uterus size is high, beta HCG is not coming down. Right? Now, most common route of metastasis is hematogenous. The most common site is lung, followed by vagina and then pelvis. Vaginal metastasis is stage 2. I will come to the stage. Most common site is suburethral metastasis. Answer this question for me. Very, very simple. Do you remember the staging of choriocarcinoma? A case of gestation trophoblastic neoplasm is seen in the lungs. What is the staging? 1, 2, 3, 4. Very simple, if you remember the staging. Okay, stage 3 is the answer. That is correct. Lung is seen in stage 3. Very good, Ashutosh, Abdul, Preetam. Yes. So stage 1 is uterus. Stage 2 is outside the uterus but within the pelvis. Means it's pelvis or vagina. Stage 3 is lungs, and stage 4 is other organs, liver, GIT, brain. And if you remember the WHO scoring, liver, spleen, GIT, everyone has a different score. So I'm not going to repeat that scoring, but I'll show you on the screen so that you just remember what you have learned, and take a printout of this particular scoring, the WHO scoring. It's very, very important. They might ask you to score it. They might ask you the treatment. So you need to know the scoring by heart. So take out printouts and put it in your bedroom, wherever you sleep, in the washroom, where you brush your teeth, so that whenever you get up, wherever you pass that area, there are certain tables that you need to know, the stagings. This is very important, WHO scoring. Now, stage 1 is low risk, we know that. Stage 4 is high risk. Okay, stage 1 is only uterus, and stage 4 is liver, GIT, all the intestinal, the intra-abdominal organs. Okay, now what about stage 2 and 3? Stage 2 is pelvis, vagina, stage 3 is lungs. How do we know whether it is low risk or high risk? In that case, we need the WHO classification. Why is WHO classification given? Why don't we just manage according to the staging? Because stage 2 and stage 3 are confusing. We don't know whether it is high risk or low risk. So that is why we need to know the WHO scoring. In vagina, the most common area of metastasis is suburethral, which is very vascular and bleeds profusely. Stage 3 is chest presentation, lungs. How will they present? They will either show a snowstorm appearance, just like sonography of the uterus, or they may be a cannonball appearance. A cannonball appearance, that is a focal growth within the lungs. That is showing you the GTN, the metastasis. And the symptoms here will be cough and hemoptysis. Right? Now, scoring. You want me to do the scoring? I think it will be just a waste of time, because it is just a copy of what is written in your books. How will I remember it? If I was a student, what will I do? I will just first of all tick mark the criteria which are not going up to score 4. So there are 6 criteria out of 9. So out of 9. So this is, sorry, this is 1, this is 2, this is 3, this is 4, right? Then 5. Then 6, then 7, then 8 and 9. So you can see out of 9, there are, sorry, yeah, out of 9, there are 6 criteria in which all the 4 scores are not being used. So 0, 1, 2 and 4. There is no scoring like 3, and it starts from 0, ends at 4. So there are 6 criteria where all the scores are not used. Age, it is only 0 and 1 being used. In Antecedent pregnancy, it is only 0, 1 and 2 being used. So this one. Then here it is largest tumor including uterus, less than 3, 3 to 4, more than 5. Then number of metastasis can be 1 to 4, 5 to 8, more than 8. So remember 0 is not being used because number of metastasis can never be 0. If metastasis is there, it cannot be 0. Okay. Largest tumor size, it has never gone up to score 4. Blood group, it starts with 1. It's either O or A, it's 1, 2 is B and AB, nothing like 4. And prior failed chemotherapy. So single drug and more than 2 drugs. So this is how I will remember. 6 out of 9 are not using all the 4 scores. The rest 3 are using all the 4 scores. So you need to remember 6 up to 6 is low risk, 7 and higher is high risk. Okay. And how do you decide single dose or multiple dose chemotherapy? Low risk is single dose methotrexate. How do you give it? 1, 3, 5 and 7. So from 1 till 8 day you are giving methotrexate. Alternate day you are giving folinic acid because methotrexate is causing toxicity. You need to give folinic acid. In case the patient's liver is damaged and she is having jaundice, in that case instead of methotrexate you give actinomycin D. That was again a question which I saw in the groups where one of the student had asked. I don't have the question right now, but yes, they will ask you instead of methotrexate what is the substitute for methotrexate if the patient has jaundice. Then it is actinomycin D. So in complete mole, when we were giving chemotherapy, we were giving methotrexate 5 times a day. 5 times a day, and we were giving it on day 1, day 7 and day 8, sorry, after every 7 days, and day 15, 3 cycles. Here we are giving it, first cycle is finishing in 8 days. So from 1st April till 8th April, for example. Then you again start from 15th April to 22nd April. Then again you start from 23. So this is how it goes, 23 to 30th April. So this is how every week you are giving her 1 week rest in between, and you're giving her 3 cycles of methotrexate plus folinic acid. 1, 3, 5, 7 and 2, 4, 6, 8. This is how we do it. They will ask you the dose. Methotrexate is 1 to 1.5 milligram per kg. So on an average, we will give 50 milligram to the patient because averagely the women are 50 to 60 kilogram in weight. So we'll give them 50 milligram that is easily available in the market, and the next day we'll give a folinic acid. Okay. Folinic acid is 0.1 milligram per kg per day, and this is 1 to 1.5 milligram per kg. IM, it has to be given methotrexate. Okay. If the female doesn't desire fertility, you may do a hysterectomy and give her chemotherapy. Repeat this course every 7 days till the HCG comes back normal, less than 5. Follow her up for 3 more cycles of chemotherapy after the value normalizes, and follow the patient for 1 year. You have to follow her up for 1 year. Very important. You have to follow this patient for 1 year. Okay. In molar pregnancy, you don't need to follow for 1 year. You have given methotrexate because the HCG levels were high and the HCG has come back to normal. The previous 2 values were normal. So then you can just leave her. But in choriocarcinoma, you have to follow her up for 1 year. Answer this question. Now we have moved to CIN and cervical cancer. Now, what are the ACOG and ASCCP guidelines for age-related cervical screening? More than 65 years, less than 21 years, 21 to 65 and teenagers. Tell me. What is the answer here? Okay, yeah, you're right, Ashutosh. Abdul, yes, it is 21 to 65. Let us just recapitulate what we have read before. PAP screening guidelines by ASCCP revised by ACOG in 2013. Remember the year also, 2013. You may get confused sometimes when we are actually sitting and doing the MCQs. We don't know where our brain is running, and sometimes even simple things might confuse us. So 2013 it was revised by ASCCP, that is American Society for Colposcopy and Cervical Pathology, American College of Gynecology. Okay. 21 years of age regardless of the age of first sexual intercourse. So American guidelines, because the sexual activity is much before than the Indian guidelines. So the WHO has come up with a new guideline. WHO says in resource poor countries where the sexual activity is not as much as compared to the Western population, they have said that you can start screening at 30. In America, by 21, they accept that most of the females will be sexually active. In that case, you have to start the screening irrespective whether she was sexually active at the age of 15 or 16, but from 21 onwards you have to start the screening, not before that, because then she'll be very young for this kind of screening. In case she has not been sexually active till 21, then you have to wait till she becomes sexually active. You have to wait for 3 years after the first intercourse, then you do a pap smear. It takes about 3 years for anything to develop within the cervix. After 65 years, so basically 21 to 65 is ASCCP and ACOG. After 65, they say that if the patient never had a history of CIN, you can stop it. Or if she had CIN, but the 3 consecutive pap smears, every 3 years you're doing it. So almost 9 years. The last 9 years, 3 pap smears, 3 yearly pap smears were normal. Or the co-testing, which is done every 5 years. So last 10 years, 2 tests were normal. In that case, you can just leave it. Co-testing is HPV DNA with pap smear. You know that, right? Women with prior treatment of CIN2, CIN3, adenocarcinoma in situ, CS cervix. So these are the high risk ones. They have to be followed for at least 20 years. Okay. So in CIN, when it is HSIL or full-blown cervical carcinoma, adenocarcinoma, the patient has to be followed up for 20 years. So this is the ASCCB guideline. PAP screening for by ASCCB, it says after hysterectomy for benign disease, no screening is required. After hysterectomy for HSIL, if it has been LSIL, what will you do? They don't say anything about LSIL. But for LSIL, you may do a PAP. Maybe if after 6 months, if it is normal, you can leave it. You can maybe just follow her for 1 year. LSIL. But in HSIL, you have to follow her up for 20 years. If you can remember, 6 monthly in the first 2 years and then followed by every 3 years, just like the normal routine, you do a pap smear every 3 years. From the vaginal cuff, you do a pap 3 yearly, and you have to monitor her for 20 years because she has had HSIL, that is high grade lesion. If HPV vaccine has already been given, don't get confused, the screening has to be continued. HPV vaccine is not going to reduce the chances of she getting infected. It is going to reduce the chances of she getting integrated with HPV and developing a high grade lesion. Okay, so HPV vaccine is protecting 99% of the cancers and high grade lesions because it is a vaccine acting against the virus, but it will not prevent infection. So you have to do the routine screening and treat her. Then HPV testing, when is it recommended? It is recommended after 30 because before 30 we assume that the sexual activity is more, HPV keeps coming and going, and the immunity of the patient is very good. At that time, less than 30, the integration with HPV will not happen. The body will automatically remove the HPV from the body. So it has to be done after 30. Pap smear with high risk HPV testing is known as co-testing. If it is done combined, then you don't have to do it every 3 years, you do it every 5 years. Basically, you're trying to protect your resources. You're trying not to use your resources so much. Don't exploit the resources. So it is not recommended in less than 30 years. In cases of abnormal PAP reports, in cases of untreated CIN, or in cases of post-treatment surveillance also. Depends upon what kind of question they're asking. Sometimes the option may be HPV testing after treatment of CIN2. Sometimes it might be colposcopy. So it all depends how the question is framed. There is a question, I'll just come to that. Now, it's unnecessary. HPV testing is unnecessary in cases with typical warts, when you can see that high-grade lesion is there, cervical cancer is there, or warts have developed. What will you do by gaining HPV DNA testing? You know it is HPV. Okay. Co-testing, if it is negative, it has a high negative predictive value. So you can wait for 5 years. It is said 5 to 10 years because it depends upon the kind of population we are dealing with, the resources available. But generally 5 years for co-testing. And in HIV positive, it is 3 years. So remember 3 years and 5 years, although the range is 5 to 10 and 3 to 5. But 5 years for co-testing in a normal patient, and a patient who is HIV positive or living with a HIV positive partner, then it can be 3 years. WHO says that for resource poor countries, where the patients are, that population is too high, the resources are poor, we cannot do so much triage and so much testing, then you have to just see and treat. Whatever you have diagnosed, just treat. So you have to start the screening at 30 and stop at 50. Don't do it after 50. Okay. So if living with HIV positive patient, then you can start with at 25 years. Otherwise, start at 30, stop at 50. If previous 2 screenings were normal, just like what we did previously. In 65 years of age in ACOG, it says previous 3 screenings, means previous last 10 years screenings were normal, whether 2 co-testing or 3 simple PAP. But here, stop screening at 50 if previous 2 screenings were normal. Now, WHO, I'm not going to the details. It is saying that you can either do a see and treat approach, or you can do a see, triage and treat approach. So basically, it depends upon what kind of resources and what kind of patient population you are dealing with. Okay. Now, primary test can be HPV DNA or VIA. So VIA is visual inspection, which is done in the villages by the nurses. Just apply 5% acetic acid. If it is coming up, popping up white, then you may do a biopsy, you may send her for further treatment, you may do a cryo, you may do a cautery. So see and treat. Just one test and you treat. Okay. After treatment, you have to follow her up for 1 year. So HPV DNA, if it is positive, treat it. VIA, if it is positive, treat it. The other approach is much better. That is, see, triage and treat. What it says is, don't just treat immediately. You have seen just one thing, so do another test. No, why just see a VIA that it is coming up white, popping up, and then you're treating it? No, don't do that. Do HPV DNA or do VIA, and then if one is positive, do another test. So do HPV DNA followed by VIA or VIA followed by HPV. If both are positive, then you go for either colposcopy, you send her for biopsy, you send her for cryotherapy or whatever. Okay, so HPV plus VIA is better than simply one test, and of course HPV DNA is much better if the resources are there and the patient can afford. Primary test PAP or HPV DNA, then you can do another test, that is triage. See, triage and treat. This was something new in Williams. So that is why you need to know this. Now, solve this question for me. 30-year-old woman is diagnosed with carcinoma in situ of the cervix and no obvious macroscopic growth. What is the next line of management? Tell me. So, is it hysterectomy? Is it conization? Is it colposcopy and biopsy? Or is it follow-up after 6 months? What will you do here? Tell me. She's 30, she's young. Okay. She has been diagnosed with carcinoma in situ, so that means HSIL. There is no obvious macroscopic growth. You cannot see any growth. What will you do? Okay. So D and C. Somebody is saying follow up after 6 months. Why will you follow up after 6 months, Preetham? You cannot leave a patient with carcinoma in situ. You have to treat her, right? You will not do a hysterectomy in a 30-year-old patient. You will not follow her up for 6 months unless you treat her. So the option can be either conization, colposcopy and biopsy. So I will go with colposcopy and biopsy here. Why not conization? Somebody will say, why not conization, ma'am? Because the carcinoma in situ has been diagnosed. But did they tell you that it was a biopsy diagnosis? It might be just a PAP diagnosis. So you have to confirm that it is definitely carcinoma in situ. So colposcopy has to be done. Even conization, a blind conization is never done. It was done maybe when our consultants were working. Maybe, say for example, I finished in 2000, my PG. So another 20 years back. So that was long back when colposcopy was not available. At that time, we were doing cold knife conization, simply going with the knife and cutting a cone outside, cutting a cone like this. But now we do everything with colposcopy. So the best answer is colposcopy and biopsy. Okay. Then next question is, 30-year-old woman came with cervical discharge, pelvic pain. These are the two complaints. She's again young. Pap smear is showing LSIL. So it is LSIL through pap smear. How will you manage the patient? What will you do now? So it is LSIL. You will repeat the pap. You will do a hysterectomy. You do colposcopy biopsy. You do a cone biopsy. Tell me. And also tell me, if the patient was 60 with postcoital bleeding, what will you do? What if the patient had ascus instead of LSIL? How does the management change? First of all, answer this question. So, young patient having cervical discharge and has been diagnosed with LSIL, which is very common. Low grade CIN1, it is a low grade squamous intraepithelial lesion. What will you do? Anybody? We're taking so much time. Come on, Ashutosh. Come on, Preetham. Who else was answering? Abdul? Isha, Akshat. Okay. Ashutosh is saying A. Preetham is saying A. Okay. Yes, I know it is confusing because you know that most of the LSIL will actually go away on their own. 60%, 70% will regress. But you can't leave an LSIL when the report has come. So you have to do a colposcopy plus minus biopsy. You may not do a biopsy if you are sure in colposcopy that this looks like a normal lesion. But you cannot diagnose just by looking at it. You have to do a biopsy. Generally, colposcopy with biopsy is the recommended treatment for LSIL also. So I'll come to that chart as to how you manage as per the PAP report. Okay. Now, if this patient was 60 instead of 30, and instead of cervical discharge, she was having postcoital bleeding, or she may be having just simply cervical discharge. You will not believe, I just recently, 6 months ago, I had a patient of around 55, 60 years. She had excessive cervical discharge, and by just looking at her, she did not look cancerous. She looked absolutely normal. There was no abnormal bleeding, but looking at the cervix, it was unhealthy and it was a very foul smelling discharge. There was no growth. So I just did a biopsy and it came back as a very early cervical carcinoma. So yes, if it is a patient with LSIL, but she's 60 with postcoital bleeding, sorry for this. 60 with postcoital bleeding, the answer will be hysterectomy. Here the answer will be hysterectomy. Okay, but if the patient had ascus and PAP, it was not LSIL, it was ascus. In that case, you will follow her up, repeat a PAP smear after 6 months. Do you understand? Ascus, LSIL, HSIL, they all have different ways of managing. So, depending upon the age, depending upon the PAP finding, you will manage the patient. But if the patient was 60 with ascus, same. Follow her up with PAP smear after 6 months. Okay. Sometimes you may do a colposcopy with biopsy in 60-year-old depending upon what all symptoms she's having. If she's having symptoms, why will you do a PAP in a 60-year-old? She will have symptoms, then only you will do. So the option will be either repeat PAP or you do a colposcopy biopsy that comes back ascus, then you repeat a PAP after 6 months. Okay, understood how you approach a question? Now, approach to this question is cervical discharge, pelvic pain, LSIL. Yes, LSIL I told you. Repeat PAP after 6 months. Once the diagnosis is confirmed, again repeat cytology after 1 year. That is done. Basically, once you have diagnosed with colposcopy in LSIL that yes, it is CIN1. So the answer is colposcopy with or without biopsy. That is recommended. Cone biopsy we will not do in this case because to remove a cone, it is very extensive surgery, very hemorrhagic. It can lead to a lot of bleeding. So we will not do in a LSIL. Hysterectomy not recommended unless the patient is postmenopausal and she's completed her family, and that too it is a persistent LSIL. Then you will do it. Why will you do a hysterectomy even in a 50-year-old patient? Even I mean, now the patients are very kind of conscious about their uterus, about everything. They don't just want to get anything removed because they have stopped conceiving. They don't want any more children. That doesn't mean that the uterus can be removed. Okay, so coming to management of CIN as per the PAP report, very important. Ascus, only 5 to 10% chance of converting ascus to CIN 2-3, that is HSIL. Very rarely it will convert into HSIL. Cancer is seen only in 0.1%, 1 to 2 out of 1000. Age 21 to 24 in ascus. You will just simply repeat PAP. If it is abnormal, then you go for colposcopy. So repeat PAP after 6 months. Right? If she is more than 25, you may go for HPV DNA testing. So in this case, our patient was 30-year-old. So if it was ascus, you may do, if it was an option here, HPV reflex testing. What is reflex and what is HPV? Do you know the difference? HPV co-testing is when you are doing a PAP smear and you're requesting the pathologist to do a PAP along with HPV testing at the same go. Reflex testing is when the report comes back, PAP is positive, showing HSIL, showing some reactive changes, coilocytes are there, and then the pathologist requests you that can I add HPV test to this? That is reflex testing. It's one and the same thing. The only thing is, as a gynecologist, you have not requested HPV initially. So that is not co-testing. If the pathologist tells you there is a problem, now you ask her to do or ask the pathologist to do the reflex testing now or HPV testing on the same sample. That becomes a reflex testing. Okay, difference between reflex and a co-testing. So that is it. So combined testing after 3 years, you may be done. It may be done. Reflex DNA testing can be done after 25 years if the patient is having ascus, and if it is positive, then we may do a colposcopy. LSIL, the growth is visible, you will do a punch biopsy. Generally, growth is not visible in LSIL. So, if it is not visible, you do a colposcopic guided biopsy. You may do an endocervical curettage if you cannot see the transformation zone, or you may see a glandular abnormality. You may do an endocervical curettage. Confirm CIN with colposcopy, then you follow up after 6 months, and co-testing HPV DNA at 12 months. So, basically, LSIL should be followed up for 1 year only. LSIL, ascus, 1 year follow-up is enough. HSIL, carcinoma in situ, 20 years follow-up. Even if the uterus is removed, you follow her up with PAP every 3 years for 20 years. Okay. In adolescents, only annual PAP is recommended. Only annual PAP is recommended in adolescents. Now, then coming to 21 to 24 and more than 25. Just like ascus, if she is young, very young, less than 25, colposcopy may not be indicated. You may simply leave co-testing also. We don't need to do HPV testing. As I told you, HPV is recommended only after 30. Postmenopausal women, colposcopy is indicated. Repeat cytology at 6 to 12 months, HPV testing. CIN1 is persisting after 2 years. You may do a cryo, although CIN1 doesn't need any treatment, but sometimes you may do a cryo. In pregnant females, you may wait for 6 weeks. Pregnancy with cervical carcinoma, I have not included in this particular chapter, in this particular session. But yes, you can go through my lectures in Manipal Medace. You can go through the free sessions. You can go subscribe to it if you want to know the details. So pregnancy depends upon what week gestation of pregnancy she has been diagnosed with cervical problems, whether it is LSIL, whether it is HSIL, whether it is carcinoma in situ, or microinvasive or macroinvasive carcinoma. So it all depends upon the gestation, the type of report, and of course the maturity of the baby. Now, HSIL, the dictum says it has to be colposcopy and biopsy. A punch biopsy if the growth is visible using titular forceps. I have not included the photograph of titular forceps, but you should know how it looks like. And it may be colposcopic directed biopsy with endocervical curettage if required. Biopsy, there was a question whether it requires anesthesia. No, it does not require anesthesia. And what are the agents which will reduce bleeding in case of biopsy when you're doing a biopsy? The bleeding can be reduced with the help of silver nitrate or ferric subsulfate. These are the solutions that can be put on the cervix so that the local hemostasis can be prevented. Sometimes we even have to take a stitch. Practical experience, I'm telling you. Sometimes if the mass is very, very friable and the packing is not helping you, you are packing with ferric subsulfate or Monsell solution or silver nitrate. Even then it is not working. You may need to take a stitch, or sometimes even you may need to do a cautery. Recurrent HSIL, you will do a hysterectomy, especially if she has completed a family. Cone excision leap biopsy. Leap is basically a loop attached to a tungsten loop or a stainless steel wire. It is attached to the stick and it is attached to the cautery, and you cut that lesion. Now, answer this question for me. A 40-year-old woman presents for routine gynecologic examination. She has a history of HPV infection and CIN2 that was treated with loop electrosurgical excision procedure LEAP 2 years ago. On pelvic examination, there is a small area of erythema on the cervix. The most appropriate management at this time is what? She is 40. She is not that young. She is not that old. History of HPV. She has been treated with LEAP CIN2. Was diagnosed 2 years ago. It was done. Now there is a small area of erythema. What will you do? It is simply erythema. Will you just simply observe and repeat PAP in 6 months? Will you do an HPV testing? Will you do a colposcopy, or will you do a biopsy? I'll give you 20 seconds. Okay, so what answers do we have? D and C, Ashutosh and Preetham. Okay, so I will go with colposcopy here because she's showing a lesion. You will not observe and repeat pap smear in 6 months. She has come to you with erythema. There is maybe a recurrence there. It's a CIN2, right? And you're following her for 20 years. So within 2 years, if she's coming back, you have to do something. So definitely not observe. Definitely not biopsy. Why will you do a biopsy without a colposcopy? So colposcopy plus minus biopsy if it is required. And there's a confusion between HPV DNA testing. In this case, because they're telling that there is a erythema there, so first you do a colposcopy. If you think HPV DNA testing is required, you may do a colposcopy with LBC again or a pap smear again, and then you can send the sample for HPV testing. Because she's above 40, so yes, HPV testing can be done. But the first thing will be colposcopy. 40-year-old woman giving a history, treatment and erythema on the cervix. Observation and repeat pap smear can be done only once she is completely treated. So in CIN2, you have to follow her for 20 years. So you can't just observe. HPV DNA testing not recommended in treated CIN2. It may be done when you're following her up, but now she's come back with a problem. Colposcopy is better because LEAP sometimes can miss the microinvasive carcinoma. The microinvasive carcinoma, LEAP can miss it. So in suspicious examination, colposcopy with biopsy is very important. Naked eye biopsy we don't do anymore. Now, again coming to the cervical cancer staging. The cervical cancer staging, very, very important. 1 second. Yeah. Stage 0 is CIN3 and carcinoma in situ where the basement membrane is intact. Stage 1 is strictly confined to the cervix. Stage 1A, 1A1 and 1A2. So 1A is always microscopic and 1B is macroscopic. So microscopic carcinoma, less than 5 mm deepest invasion, less than 3 and 3 to 5. So I'm just recapitulating what you have read. I'm not going to the details because it's just something you need to remember. There's no rocket science in it, okay? So when it is less than 3 mm, that is A1, and A2 is between 3 to 5. Both are microscopic. In that case, you will simply do a conization or type 1 hysterectomy, TAH. You may not do a BSO. Simply TAH, total abdominal hysterectomy. it doesn't need a radical hysterectomy till stage A1, less than 3 millimeter. As soon as it becomes 1A2, it is radical trachelectomy or a type 2, type 3 Wardheim or radical hysterectomy. Means it is still microscopic, but it is more than the pathologist is saying, more than 3 millimeter microinvasion, then you go for a radical hysterectomy. But we don't do a pelvic lymphadenectomy in the first case. Second one, we are doing it. Remember, in stage 1, because it is microscopic, because it is a microscopic carcinoma, we don't give radiotherapy. So in cervical cancer, stage 1A, in microscopic carcinoma, no radiotherapy. Lymphadenectomy not done in 1A1, but it is done in 1A2. But if in 1A1 it becomes LVSI positive, the pathologist is good enough to tell you that lymph vascular space involvement is there. Then in that case, you have to do a pelvic and para-aortic lymph node dissection, just like you did in endometrial carcinoma stage 2 when it went to the cervix. You did a para-aortic as well as pelvic, both lymphadenectomy. In this case now, because LVSI is positive, you do a radical trachelectomy, radical hysterectomy, radical trachelectomy. Trachelectomy means removing only the cervix. Radical means parametrium along the cervix, not the uterus, but parametrium which is on the side of the cervix. So remove that. Cervical conization may be done and type 3 hysterectomy may be done. Okay. Now coming to stage 1B, it is macroscopic now. B1, B2 and B3. B1 is less than 2, B2 is 2 to 4 and more than 4. So from B3 onwards, once the tumor is more than 4 centimeter, we don't do any surgery. No surgery. No surgery after the tumor becomes more than 4 centimeter. No radiotherapy till it is 1A. Means it is microscopic. Okay. So clinically visible stromal invasion has to be more than 5 because now it is 1B, more than 1A, and preclinical size, but the size has to be more than 1A. So less than 2, 2 to 4, more than 4. So what is the treatment here? 1B2, that means it is 2 to 4 centimeter because 1B1 is included here. 1B1 is here. Radical trachelectomy because the size was less than 2 centimeter. Okay. Once it is between 2 to 4, we do a type 2, that is Wardheim hysterectomy or a radical hysterectomy with radiotherapy with pelvic lymphadenectomy, pelvic and para-aortic. Then coming to A2, A2 and 1B3. What is 2A1? 2 is basically cervix involving beyond the uterus but not till the pelvic wall. So this is the uterus, this is the cancer here. It is spreading in the upper 2/3 of the vagina till here, or it is going to the parametrium, but it is not involving the lateral pelvic wall. So this is the cancer. Let me use the green color here. This is the cancer here. So this is stage 2. Stage 2A is when it is involving the upper 2/3 of the vagina without parametrial involvement. Stage 2B is parametrial involvement. Once the parametrial involvement is there, we don't do any surgery. Okay. So 1B3 and 2A2, no surgery. No surgery because the size has increased. Even in 2A2, the size is more than 4 centimeter. Okay. So 2A2, 2B, when the parametrium is involved, and beyond 2B, we don't do any surgery. So either size more than 4 centimeter or involvement of the parametrium, no surgery is recommended. So in 1B3 and 2A2, the size is more than 4 centimeter, simply radiotherapy. Chemoradiation means you add cisplatin. Cisplatin is a key sensitizer, radiosensitizer, which increases the sensitivity of the cervical tissue to radiotherapy. Okay, so cisplatin can be given. CCRT is combined chemotherapy and radiotherapy, palliative surgery or radiotherapy because now it is extending towards the pelvic wall involving the ureter. Then 4 will be rectum, bladder and the other organs. Recurrence pelvic exenteration has to be done in cases of recurrence if at all the patient can tolerate it, or it can be simply palliative radiotherapy. Now, stage 2A we have done. Stage 3 will be extending to the lateral pelvic wall and the lower 1/3 of the vagina. So that is, here we said it is not involving the lower 1/3. Now it has come to the lower 1/3 of the vagina, or it has extended till the pelvic wall. That is stage 3. Okay. And stage 4 is beyond the true pelvis. That means adjacent organs, bladder, bowel and rectum, and then spread to the distant organs. Now, answer this question for me. 48-year-old woman had a radical hysterectomy with for a 6 centimeter squamous cell carcinoma of the cervix. On final pathology report, the parametrium was seen to be free of tumor. So no parametrial involvement. So it is less than stage 2B. 2B is what? Parametrial involvement, and the size is 6 centimeter. Okay. What stage is her cervical cancer? Is it 1B3? 1B3 is above 4 centimeter. Yes. 1B3, or is it 2A? It can't be 2A1 because it is less than 4 centimeter. Here it is 6 centimeter. So what is the answer? Tell me. It is definitely not 1B1 because 1B1 is less than 2 centimeter. 1B2 is 2 to 4 centimeter. It is either 1B3 or It can be 2A2. It cannot be 2B because there is no parametrial involvement. So now we are left with, I've already given you the answer. The answer is 2A2. It is 2A2 because it is 6 centimeter, so more than 4 centimeter, and no parametrial involvement. This is how they will ask you the questions. Okay? Yes, Anil, it is C. Now, types of treatment available for cervical carcinoma. It is a very radiosensitive tumor. So, if the surgery is not possible or if surgery has to be combined, then radiotherapy is the first treatment. Chemoradiation is something new. That is, they are adding cisplatin to the radiotherapy treatment. No surgery once the tumor size is more than 4 centimeter, means 1B3, or the parametrial involvement is there, 2B. Okay, radiosensitization cisplatin increases the sensitivity of squamous cells for radiotherapy, chemoradiation. All stages are radiosensitive, but if the choice is there, that because the survival chances and the prognosis of surgery followed by surgery and radiotherapy is same, the results are same. So we will opt for surgery rather than radiotherapy because the complications are less. No radiotherapy before stage 1B1. We know that radiotherapy is not given in microinvasive stage 1A. Okay. Then coming to primary nodes, secondary nodes, and sentinel node. What do you mean by that? The primary nodes are the ones which will be involved first. Okay. Sentinel node is the most important or the first lymph node to be involved. In vulval cancer and cervical cancer, vulval cancer, it is the inguinal lymph node. And here it is the sentinel one is the ureteric. The ureteric means just near the cervix. That is a paracervical. The paracervical lymph node. Let me write it more clearly for you. Paracervical. You know, cervix is here and the ureter is just here. So it will be a lymph node which is a part of the internal iliac lymph node, the hypogastric, but it is the paracervical or the parametrial also. It is also known as the parametrial lymph node. Paracervical, parametrial, and ureteric lymph node. This is the sentinel lymph node in cervical cancer. But the most commonly involved is the obturator lymph node. Don't get confused. Obturator lymph node is the most commonly involved. It is not the sentinel. The sentinel is the first one to get involved. That will be ureteric, paracervical, or parametrial. They are all the same. Inguinal lymph node is this one. Inguinal lymph node is the one which is being involved in the vulval cancer. That is a sentinel lymph node. Primary nodes in cervical cancer or uterine cancer will be the parametrial, paracervical, ureteric, internal iliac, obturator, external iliac, rectal, and sacral. External iliac will come in the, common iliac will come in the secondary node. So, internal iliac, obturator, and external iliac are the primary nodes. Common iliac, para-aortic, inguinal will come in the secondary node. And sentinel, I told you, this is the first lymph node to get involved. Answer this for me. 40-year-old woman comes with a history of postcoital bleeding and a visible mass seen on the cervix first speculum. Very simple question. What should be the next step? You see a visible mass. She has come with postcoital bleeding. Will you do a conization? Will you go for cryo? Will you do a targeted biopsy or a pap smear? Come on, tell me. Simplest question that I can put up for you. Anil is saying B. Okay. Anybody else? Anyone else? It's definitely not B. Why will you jump into cryotherapy? Okay, I'm waiting for more answers. Somebody? It's a very simple question. Come on. It's a visible mass seen on the cervix per speculum. What will you do? No way. No conization. Why will you jump into conization? It's a targeted biopsy. Come on. It's a targeted biopsy. You can see a growth here. You can see the cervix has a growth. So will you not just do a targeted biopsy? You don't even need a colposcopy here. Yes, thank you, Dr. Abhirami. It is biopsy. It has to be biopsy, targeted biopsy, because you can see it. So it's a titular forceps that you are using. Titular forceps, right? For the biopsy. Now, when a patient comes with postcoital bleeding, suspicion of cervical carcinoma, HSIL is high. If there is a visible mass, direct punch biopsy is done with a titular forceps or the lesion. If the lesion has endocervical extent also, then you use a Kervoken curettage. It is something like this. That is endocervical curettage. Okay, you must have seen that. Biopsy should include some normal tissue also. Remember this very important question. If the lesion is this and this is the cervix here, you have to do a biopsy from the margins because the center might be necrotic. So you have to take some normal tissue along with the necrotic tissue, along with the cancerous tissue. So the biopsy has to be done from the periphery so that the necrotic tissue is reduced. You get the cancerous tissue as well as the normal tissue so that you can compare the stroma of both and the depth of invasion can be seen. Sometimes tumorous tissue can be very, very necrotic, so you have to take extra margins. Okay. Then coming to types of hysterectomies, as I told you, I will just tell you quickly as to what these are. I'm sure you know this. So if this is the uterus here, this is the pelvic wall. Okay. There is a ureter coming here. And this is the parametrium. Okay. So type 1 is extrafacial hysterectomy, which we do every day. Type 1 hysterectomy is extrafacial and we do it from here. So we cut it from here. Let me use a different. Type 1 hysterectomy is type 1 because it is Piver and Rutledge classification, that is type 1. When it's Quirlo and Morrow classification, it is type A. So type 1 and type A are same. Type 2 and type 2 and type B are same, and type 3 and type C are same. So ABC 1, 2, 3, that depends upon that classification that we are using. So type 1 is when we are simply cutting near the uterus, not removing any part of the parametrium. Type 2, that is Burdines, will be medial to the ureter. So we are pushing the ureter laterally and we are removing 50% of the parametrium. Type 3 is the radical hysterectomy. We are going up to the pelvic wall and we are protecting the ureter by dissecting it till the origin we are protecting the uterine artery also because we are going till the end of the internal iliac artery where the origin of the uterine artery is happening. We are dissecting the ureter properly and pushing it towards the pelvic wall. So we are just going towards the pelvic wall and removing everything. That is type 3 radical hysterectomy. Now, important one-liners. Important one-liners for cervical cancer are: most common cancer of cervix is the squamous cell carcinoma. Can you tell me what slide you are watching right now? Because I can see on YouTube there is a lag. Can you see the important one-liners? Can you give me a thumbs up? Because I feel there's a lot of lag here. You can see the important one-liners, right? Okay. Thank you, KK. Okay. Most common cancer of the cervix is squamous cell carcinoma. Most common site will be transformation zone. Most common site for adenocarcinoma will be endocervix for cervical cancer. Most common lymph node involved, as I told you, will be obturator, but the sentinel lymph node is ureteric, paracervical, or it is also known as parametrial. Okay. Most common symptom in cervical cancer. That was my question when I was doing my PG, the PG third year exams. At that time, we did not have NEET or NEET PG or next. Obviously, I was passing the third year, the PG, third year PG, and the question thrown to me by the external examiner was the most common symptom in a cervical carcinoma in situ, and that is the postcoital bleeding. And I kind of blabbered. I knew the answer and that was a topic of my thesis also, but I kind of blabbered because I was just so nervous. So it is postcoital bleeding. Remember this. Generally, you will not see a lesion, and the postcoital bleeding and foul smelling discharge are the most common symptoms. Good evening, Rahul. Good evening. Yeah, postcoital bleeding, KK. Most common site for metastasis is lymph nodes, and the most common route of metastasis is lymphatics. Most common site of hematogenous spread is lungs. Most common cause of death. The most common is uremia or renal failure due to involvement of the ureter obstruction in stage 3 once it involves the pelvic wall. After that, the second cause can be hemorrhage. These are the two most important causes of death in cervical cancer. Now coming to ovarian cancers. In patients with hereditary non-polyposis colorectal cancer, HNPCC, the percentage risk of ovarian cancer and endometrial cancer respectively is how much? Okay, give me this answer. HNPCC is also known as Lynch 2 syndrome. This is Lynch 2 syndrome or also known as AD syndrome. They're all the same. In these syndromes, there is a gene which can lead to colorectal cancer, it can lead to endometrial cancer, it can lead to ovarian cancer. So Rahul says it is D. Anybody else? Endometrial carcinomas will have certain genes, like one is this one is this syndrome, the second is Cowden, and the third is BRCA. BRCA is, as the name indicates, breast and ovary is more common here. Cowden will have more of endometrial, but maximally it will be Lynch too. So I'll give you the answer. The answer is 12 and 50% respectively. 12% of ovarian cancers and 50% of endometrial cancers. So let's quickly do the theory here. Hereditary non-polyposis colorectal cancer, HNPCC, also known as Lynch 2 syndrome or AD syndrome. They have an overall lifetime risk of endometrial and ovarian cancer of 50 and 12% respectively. Most common cancer associated with HNPCCs is colorectal cancer. Remember that HNPCC, the most common cancer is colorectal. It is not endometrial. But endometrial cancer is maximally seen in HNPCC when it comes to the comparison between Lynch, Cowden and BRCA. It occurs due to which mutation? Again important for INI-CET exams. MLH, MSH, MSH and PMS. So these are the three genes that you need to know. MLH1, MSH2 and 6 and PMS2. These are the genes involved. Other familial genes or family history are Cowden syndrome and BRCA 1 and 2. Cowden P10 gene, I told you, is a gatekeeper gene. It is a very good gene which is a gatekeeper, and it protects the patients with endometrial cancer because it has a good prognosis. Okay, so 20 to 30% cases of endometrial cancer. P10 is known as gatekeeper gene for endometrial cancer as it is associated with good prognosis. BRCA 1 2 most common is ovarian cancer. BRCA is ovarian cancer. It does not lead to that much of endometrial cancer. So when it comes to the decreasing order of these, then it is 50% Lynch, 30% Cowden and almost 1 to 2% in BRCA. Coming to staging of ovarian cancer, let me just skip it because I want to do obstetrics now. It's almost about 2 hours. So let me skip the ovarian cancer staging, which you know very well. I'm not going to do the staging with you. Stage 1, stage 4. Let's do this MCQ. A 45-year-old lady came to GOPD with pain abdomen and decreased appetite. You know the ovarian cancer will generally present with gastric symptoms. On pelvic examination, a 5 by 8 centimeter solid cystic mass was palpable in the left adnexa. If you are following me on Instagram, Dr. Sonal Parihar, that is my ID, I recently just yesterday operated on a case with such a big tumor, solid cystic consistency, and because it was having a high CA125, we had to do a staging laparotomy. So what did I do? She is around 45, same age 45. Okay, so we did the staging laparotomy. So staging laparotomy includes what? It includes hysterectomy, bilateral salpingo-oophorectomy. You have to do peritoneal washings, you have to take the diaphragmatic scrapings, you have to do the omentectomy, not omental biopsy, and then you have to send it for checking whether there is a malignant ascites or not. So in this case, she underwent staging laparotomy. Right ovary was found to be normal. Only the left ovary showed a solid cystic mass. Her peritoneal washings were sent for cytology, which came back positive. So the cytology was positive, but the next ovary is not involved. So answer according to Rahul is ma'am, I got AIR 5000 in INI-CET in November 20. What to study more in OBG for better rank? Okay. See, INI-CET, you know that the most high yield topics we know are in obstetrics. I will give you a list after we finish, or maybe you can follow me on Instagram. I can make a reel for that. I've already told that in my Manipal Medace lectures. You need to be like in depth with whatever you have studied. You got 5000 rank, that means you have studied, you have revised. Only 1 month is left. You have to just revise the things and you have to go slightly more in depth for INI-CET. More of conceptual, more of clinical based questions, and yes, you are right, the answer is 1C3. So let's not discuss this, what are the high yield topics, because it is very, very important for you to finish this live session and do all the topics that we have decided. So 1C3 is the answer because it is not involving the next ovary, so it is stage 1, and it is C3 because it is basically having peritoneal washings which are involved, which are positive. In ovarian cancer, it's a recap. When do we get pelvic and para-aortic and inguinal lymph nodes? Okay, pelvic in stage 2B, para-aortic in stage 3A, and inguinal in stage 4B. Just for you to remember, this is just a recap of what I made. I did not discuss the staging with you. Pelvic, para-aortic, inguinal. Okay, so stage 2B, 3A, 4B. Inguinal lymph nodes in every genital cancer except for vulval are involved in stage 4B. Whether it's ovary, endometrium, cervix, it's 4B, 4B, 4B. But in vulva, it is stage 3A. Because inguinal lymph node drainage happens in vulval carcinoma earlier than the others. Yes, Rahul, I am from Jodhpur. Thank you. You know me. I am from Sona Media Hospital. Okay. As I told you, staging laparotomy has to be a midline incision from the umbilicus till the pubic symphysis. Ascitic fluid, if it is there, you send it for cytology. If it is not there, you do a peritoneal washing, saline wash. You take scrapings from the diaphragm. Infracolic omentectomy has to be done, not omental biopsy. Remove the entire infracolic omentum and random peritoneal biopsies with TAH with BSO. Okay. Management of the ovarian cancer, fertility preserving surgery is done when? In ovarian cancers, when it is a germ cell tumor or a sex cord stromal tumor in a young female, they generally don't have a tendency to become bilateral. So it can be done like a unilateral salpingo-oophorectomy. So that is a fertility preserving surgery. Unilateral adnexectomy. Epithelial tumors, when it is stage 1A, means it is involving only one ovary and it is grade 1, well differentiated, or grade 2, and it's a young patient, you may do a kind of fertility preserving surgery, that is unilateral oophorectomy. And borderline tumors, you don't need to remove both the ovaries. Now, stage 1A, when it becomes grade 3, it has to be staging laparotomy, TAH, BSO, chemotherapy, and the chemotherapy that we give for epithelial cancers is carboplatin, cisplatin, Taxol, paclitaxel. So these are paclitaxel and Taxol is the same, and we give it every 3 to 4 weeks, total 6 cycles. This you need to know. It is paclitaxel, cisplatin and carboplatin for epithelial. For cases which are germ cell, it is BEP. It is BEP. I'll come to that. Advanced stages, you will do only debulking as much as you can remove, and you give her chemotherapy. So ovarian cancer is responsive to chemotherapy. Advanced stages will require these chemotherapeutic agents either before surgery or after surgery, or it can be combined. It can be given intravenously or intra-abdominally. Now, bilateral oophorectomy reduces the risk of ovarian cancer by 96%. This is important. You may get it as an MCQ, and breast cancer by 50 to 80%. So, if you do a bilateral oophorectomy in a patient who is BRCA positive, then it can prevent 96% of the ovarian cancers. But why 4% are left? Because even after removing the ovary, they can be a primary peritoneal carcinoma. And breast cancer by 50 to 80% can be reduced. Okay, Rahul. That's nice. It's good you are joining the session and you're revising for your INI-CET. All the best. I hope you get a good rank and you get the dream college that you want. Okay. Now, neoadjuvant chemotherapy. I request you all, once the session is over, you can share it with your friends, because then we'll be dividing this long session into chapters, so that you can just go to the chapter that you want to revise. You don't have to revise all the chapters that I have discussed in this particular session. Now, neoadjuvant chemotherapy is 3 to 4 cycles of chemotherapy followed by interval primary cytoreductive surgery. Good for patients who are medically unfit for surgery and where suboptimal debulking is likely. Okay, so good for patients who are medically unfit. You can do a neoadjuvant chemotherapy before surgery and where suboptimal bulking is likely. Advantages of first giving chemotherapy followed by surgery is rapid clinical improvement. Subsequent surgery easier and morbidity is reduced. Optimum cytoreduction with minimal residual disease is possible. Answer this for me. Which of the following chemotherapy drug regimen is recommended for germ cell and sex cord cell tumors? So whether it is paclitaxel, carboplatin, whether it is Zumab, bevacizumab or pembrolizumab, definitely it is not this. We don't use these drugs in genital cancers. So it's either this or this. So the answer is definitely, you know the answer. It is bleomycin, etoposide and cisplatin. Cisplatin is P. Okay. So this is the regimen for sex cord and the germ cell tumors. Okay. Skipping this again. This is very important. I'm sure Dr. Ranjana must have covered this. These are the markers, the tumor markers. The yolk sac tumor will show what? AFP, alpha-fetoprotein. Dysgenoma will show, sorry, I just skipped that, Rahul. I'm just going quickly now because I want to finish it. Dysgerminoma will show what? Come on, tell me. Choriocarcinoma, definitely HCG. Epithelial, of course, CA125. Dysgerminoma will show LDH. These are the tumor markers which are very, very important for you. Okay. So I'm not waiting for your answers because I think you people also need to study more other subjects. So I just want to finish this because I have selected certain topics and I need to finish obstetrics also. Now, non-mucinous epithelial tumors will have CA125. Mucinous one will have CA19, 9 and CEA. Yolk sac tumor will be AFP and antitrypsin. AFP is also seen in embryonal tumors along with HCG. HCG is specific for choriocarcinoma, but it is also seen in embryonal tumors. So, embryonal tumor is kind of mixture of chorio and yolk sac. Okay. Dysgerminoma will be LDH and placental ALP, and granulosa cell tumor will be inhibin. Right? Now, Ovarian pathology and the characteristic pathologic features are very important. I'm not going to read this slide because you must have done this with Dr. Ranjana. If you have not done this, it is very important. The typical pathologic features for all these ovarian pathologies you need to know. Whether it's hobnail, Schiller-Dubra, Rinke's crystals, Psammoma body is very, very important. Now, which of the following suggests primary amenorrhea? Which of the following suggests primary amenorrhea? 11-year-old girl with Tanner stage 1, 13-year-old with Tanner stage 5, 14-year-old with Tanner stage 1 and 12-year-old with Tanner stage 4. Can you answer this for me? Anybody? What is primary amenorrhea? Patient is not having periods till what age? What is the definition? Okay. The definition is failure of onset of menarche beyond 15 years of age, means she is having secondary sexual characteristics. Till 15 we can wait for she to have her menses. Beyond 13 if there is absence of secondary sexual characteristics. Answer is C, KK. It is C. See, 11-year-old with Tanner stage 1, she's still developing. She still doesn't have full secondary sexual characteristics. 11 is too young. Okay. If she doesn't have any secondary sexual characteristic till 14, this is the answer. Because beyond 13, if she's not developing any breast, that means there is a problem. 11 is too young. 13-year-old with Tanner stage 5, you can wait up to 15. She is developing good amount of breast. So give her at least 2-3 years. Till 15, she may have her menarche. 12-year-old with Tanner stage 4, she is going in that right line. She may develop till 15, you have to wait. So with Tanner stage 1, it is beyond 13 when we say that it is a primary amenorrhea. So absence of menstruation till 13 or beyond 13 with no secondary sexual characteristic, good secondary sexual characteristic up to 15 we can wait. Absence of menstruation within 5 years of thalarche, no menstruation till 14 years of age with signs of hirsutism, excessive exercise or eating disorders. This is primary amenorrhea. Now, the most common cause is gonadal dysgenesis, which is Turner syndrome. Second most common cause is Mullerian agenesis. These are all the causes which I am not going to read out for you. Hypergonadotrophic, hypogonadotrophic. The third most common cause after MRKH. First is Turner's, second is MRKH, and the third most common cause is TFS, androgen insensitivity, where the genotype is XY. It is androgen insensitivity. Genetically, she is a male. Androgen insensitivity, because androgens are high, the patient is going to have very oily skin, good looking females. Androgen is high, so it gets converted into estrogen, so the breast develops very well. There is no hairy growth, there is no pubic or axillary hair because the androgens do not act. So that looks like a very good looking female with good development of breast, and these patients will need a vaginoplasty to resume their sexual activity, and basically they will be reared up as they will be brought up as a female. Cryptomenorrhea, you know what it is, imperforate hymen, that is a congenital acquired cervical stenosis. I am not going through this. These are all the slides that I wanted you to read. You will get this PDF in the Manipal Medace app. If you click on the free trial, you will get this PDF, whatever I have made. So you can just recapitulate as to what you have read. So these are all the causes of primary amenorrhea depending upon the hyper and eugonadotrophic things. Now, answer this for me. 17-year-old girl was brought by her mother to the outpatient department with complaints of primary amenorrhea with normal breast development and pubic hair. So she has pubic hair, she has breast development. So she is definitely not AIS, androgen insensitivity. She definitely has good breast, so it is not a Turner syndrome, but she is a primary amenorrhea because she's 17. So what diagnosis will you reach to? Now, blind ending vagina and uterus was not palpable on examination. Definitely you will not do a PV examination in a 17-year-old. What they would want to say is that on examination the blind vagina was there because you can see the vagina by local examination, and then sonography did not show any uterus. So what is the answer? Come on, quick. One answer I need. We get one answer and I just tell you the KK, it is right. It is Mullerian agenesis. It is not gonadal. It is not a dysgenesis because she has good breast development. Now, which of the following is not a cause of secondary amenorrhea? Not a cause of secondary amenorrhea. Very simple. Sheehan, Asherman, Turner's, PCOS. Which will not cause secondary amenorrhea? There is a lag. I can see that on YouTube we are still having the previous question. Okay. Okay, now, can you tell me the answer here? Is there a lot of lag here? Uh, okay. So I don't know whether it's a lag or you don't know the answer. The answer here is Turner's syndrome. Why Turner's? Because Turner's is going to cause primary amenorrhea. It is not going to cause secondary amenorrhea. Okay. I did not get an answer because I can see the lag. The question has just come up. Okay. Anyway, I will just continue. So it is definitely Sheehan's pituitary necrosis after PPH that can lead to secondary amenorrhea. Asherman's is one of the most common causes of secondary amenorrhea. Turner's is a cause of primary amenorrhea. PCOS again most common cause of secondary amenorrhea. Secondary amenorrhea, how do you define it? Either it is a patient who has had normal cycles so far and now suddenly for 3 months she has not had any periods, or she is a patient of irregular cycles. She never had regular cycles, but now for the last 6 months she is having no period. So 3 months, 6 months, okay, or less than 9 cycles in a year. Normally it is 12 cycles in a year, but she is having less than 9 cycles in a year. She should be investigated as secondary amenorrhea. Now, Asherman syndrome will give you a normal LH, FSH and E2 because it's a problem in the uterus. Sheehan syndrome, there will be a pituitary necrosis. Everything will be low. PCOS, there will be high LH. High LH will lead to a normal E2 and a high E1. High E1. Okay. And FSH will be low. This is a difference. In premature ovarian failure, everything will be, not everything, low E2 will cause high LH and high FSH. So these are the differences in the hormonal things. So you need to know what are the differences in the secondary amenorrhea cases as regards to the hormones. Asherman, Sheehan, PCOS and primary ovarian failure. Then coming to delayed puberty, just one slide and we finish puberty. When secondary sexual characteristics do not develop till 13 years of age, similarly just like primary amenorrhea, yes, KK, all hormones are normal here. When secondary sexual characteristics do not develop till 13 years of age, right? So that is why primary amenorrhea, we say that if there is no secondary sexual characteristic, beyond 13 it is abnormal. Menarche does not set until 16 years, that is delayed puberty. Delayed puberty more common in males, precocious puberty more common in females. Normal upper limit of menarche is 15 years, just like we read in primary amenorrhea. Males, either there is no testicular growth till 14 years, then that is delayed puberty. Most common cause in males is constitutional. In females, generally it is pathological. And the most common cause I told you is Turner's, followed by Mullerian, Rokitansky, MRKH, followed by the third one was AIS, androgen insensitivity syndrome. Now, this slide I think is very important for you, for people who do not understand what is Swyer syndrome, what is prior gonadal dysgenesis and what is Turner's syndrome. Turner's streak ovaries, in Swayer's there will be streak testes. It's XY and XX and X0 here. Okay, these are the differences. Short stature, web neck, CVS problems are seen only in Turner's, nothing else. Nobody else will have these problems. In Swyer syndrome, because it's a testes, so hypoplastic uterus will be there because it's a dysgenetic testis. So MIS will be absent. Mullerian inhibiting hormone will be absent. Testosterone will not be proper enough for the Wolffian duct to develop. So hypoplastic uterus because there is a very low amount of estrogen. Externally, they may look like an under-virilized male. Under-virilized male. So they will have probably a very ambiguous genitalia. They are technically males, but they don't look like a proper virilized male. Okay. Here it will be an infantile female. Here it will be a normal female. Now, match the following. I will do this for you because it's very simple. MRKH will have 46XX. Swayer's is 46XY. Androgen insensitivity is again 46XY. Turner's is 46X0. Because the time is short, so I'm just not letting you answer this question. IQ, yes, Turner's IQ is good. I have seen Turner's patient. The IQ is actually good. It is just the looks, the web space, the cubitus valgus they have. The hands are like this, and then the shoulders are like this. So they look abnormal, but the IQ is good. It is not like mental retardation of Down syndrome. Now, Swyer syndrome, just quickly telling you, pure gonadal dysgenesis, the testes are not working. Testosterone is not enough for the Wolffian duct to develop. It degenerates. There is no AMH because AMH comes from the Sertoli cells. So that is why Mullerian duct will develop, but it will be infantile because estrogen is not enough. 85% are unknown. Gonads are testes and dysgenetic, and the external genitalia may look like a female. So they are male hermaphrodites. Male pseudo hermaphrodites. Right? Sorry, male because it is XY, and because they may look like female, they may look like a male. It's ambiguous genitalia. Undescended testes, increased chances of malignancy of testes. Now, there is no ambiguous genitalia. Okay, no ambiguous genitalia at birth. I've written here, but I told you it may be ambiguous. So you can say it is an under virilized male. The genitalia of exclusion is female. If the testosterone is not enough, the patient will develop into female organ. So it may look like a female. Generally, ambiguity is not there. So, but there is a confusion. There is an under-virilization of the male. Adrenarche does not happen. Breasts do not develop as E2 is not there. Delayed puberty, normal height, primary amenorrhea, high FSH and high LH because testosterone is not there to give the negative inhibition. Complete androgen insensitivity. Here the 46XY is there, testes is acting, but enough androgen is there, but it is not acting on the receptor. So high androgen getting converted into estrogen. As I told you, good breast, they have a lot of acne, or you can say oily skin, and the pubic hair and axillary hair is absent, and the internal genitalia will be absent because neither Wolfram duct nor Mullerian duct will develop. But externally they look like females because they have breast and they have a very small short vagina with no uterus at all. So the vaginoplasty can be done for them to continue with their married and sexual life. Precocious puberty, appearance of any secondary sexual characteristic before 8 years, that is breast before 8 years, and menarche before 10 years is basically precocious puberty. It may be isosexual when entirely you can say the sequence of puberty is followed. Means thalarche, then adrenarche, pubarche is happening, and later menarche. But it can be heterogeneous when there is excessive androgen coming from ovary or adrenal. Then she may develop axillary hair, pubic hair before, menarche come late. So that is not isosexual, that is heterosexual. 90% are idiopathic because they are constitutional. Precocious puberty very common in females, and 90% will have no organic cause. Now, coming to obstetrics. Okay, almost done with gynecology. Most important topics I've done. Primary gravida is in labor, station -1, cervix posterior 30% effaced, 1 centimeter dilatation, consistency soft. Calculate the Bishop score. Shall I do it for you? Because it is a very simple, you need to know this chart. You need to know this chart. You need to know that Bishop and modified Bishop, how they are different. Effacement is subjective because if I do a PV, I may say it is a 50% effacement. If you do a PV, you may say it's 20% effaced. So that is why now they have included length of the cervix. Rest all is same. The only thing is here they are starting with station -3. Here they are starting with station -2. In Bishop, it is 0, 1, 2, 3. Here it is only 0, 1 and 2. It's simplified. Modified Bishop is simplified. So depending whether they are asking modified Bishop score or a proper Bishop score, you need to know this chart. Okay. Now, again, very important question. Do you know this? How you actually identify the fetal position? First of all, students, you have to see the sinciput and the occiput. Occiput is triangular. Sinciput is diamond shaped. Denominator in the vertex position is always occiput. You know that. So if the occiput is pointing anteriorly, it will be an anterior position. It will be posterior if it is pointing posteriorly. So in this place, where is the pubic symphysis? This is the pubic symphysis, and this is the sacral promontory. So the occiput is pointing posteriorly. So it is definitely OP position. Now right or left? For me, it is my right. So for the patient, it will be left. Her anatomical left. So it will be left occipital posterior because the patient is lying in front of me. So she's kind of like a mirror image of me. So my right means her left. So it is LOP. Okay. Then coming to modified Robson's classification. Now, modified Robson's class 1 will include what? It will include nullipara, singleton, cephalic and spontaneous labor. So why I want you to basically remember this. First of all, you need to know that there are 10 group classification systems where the cesarean sections have been grouped into 10 groups according to different categories of the pregnancy. So category of pregnancy means what? Category means it is either multiple pregnancy, it's a multiple pregnancy, or it's a malpresentation because they have included cephalic, breech, in malpresentation breech is included, transverse lie and oblique lie have been included. Okay. Past obstetrical record will tell whether it's a previous LSCS or it's a multi or it's a primary. Course of labor and delivery, it will tell whether it's a spontaneous labor or it's an induced labor or it's a pre-labor. She's not in labor at all. And the gestational age, whether it's a preterm or a full term. This is how the Robson's classification goes. So these 4 criteria, they may make an MCQ for you, and you have to decide what are the categories divided into. So different categories of pregnancy, past obstetrical record, course of labor and delivery, and gestational age of the pregnancy. Okay. So the first thing was that they asked you was nullipara, singleton, cephalic, full term, spontaneous labor. In the second, instead of spontaneous, they are putting pre-labor or not in labor or induced labor. Again nullipara. Third and fourth are same, but only thing is, instead of nulli, they have changed it into multi. So it's a multi now. It's a multi with spontaneous labor. It's a multi with either no labor or induced labor. Coming to 5, it is simply a multi-para with singleton, cephalic, full term with previous cesarean section. So 5 is a multi with a previous cesarean section. Till here, it is absolutely fine. 6 is singleton breech. 7 is multi-para breech. 8, 9, 10. 8 is a different category. There's a multiple pregnancy. 9 and 10, why I found it a bit absurd is 9 and 10, they have just included nullipara with transverse oblique and then preterm. They have not included multipara with transverse or oblique, and they have not included multipara with preterm. So these 2 are missing, but they are happy with just 10 classifications. So it's very simple. So first one is spontaneous, then comes induced, first 2 are nullipara, and then next 2 are multi. This is how it goes, and it's very simple to remember. And they may ask you this question. It is important. Okay. Then which of the following is false regarding management of diabetes in pregnancy? Tell me, somebody. Okay, I'll wait for this answer. Elective cesarean has no role in reducing incidence of brachial plexus injury. In a patient being planned for induction of labor, night dose of intermediate insulin is given as planned and the morning dose is withheld. In active labor, if the RBS, the random blood sugar, is less than 70, dextrose 5 is started at 100 to 150 ml per hour till the RBS becomes more than 100 mg%. Capillary blood glucose monitoring is kept at fasting around 95, postprandial 1 hour 140 and 2 hours 120. Tell me what is wrong. What is not right? As I told you, GDM is very, very important. Anyone? Okay. Why is it taking so long? It's a very simple question. If you have read diabetes, gestational diabetes in pregnancy, it's a very simple question. Okay. So the answer is elective cesarean section. Yes, right, KK. Good. I was waiting for your answer. Elective cesarean has no role in reducing incidence of brachial plexus injury because it has a role. That is why macrosomic babies, it is better to deliver by elective cesarean, especially the babies who are above 4.5 kgs. Okay. So now coming to quick recapitulation of the diabetes pregnancy in pregnancy monitoring and management. Glucose monitoring, diet and exercise, that is MNT, medical nutrition therapy, is given. Should be continued for at least 2 weeks to achieve the following. Metabolic goal is fasting less than 95, post meal 1 hour 140, 2 hours to 120, HbA1c preferably 6 or less than 6.5, average glucose less than 100. Now, if the patient is being induced, first of all, induction is not a contraindication. You can induce. Insulin requirement during labor, because she is not eating, will decrease. So you have to be careful. Okay. It is better for the glucose to go high slightly rather than hypoglycemia. Hyperglycemia is better and less dangerous as compared to hypoglycemia. Early hospitalization may be required to stabilize the diabetes, to minimize PET, polyhydramnios, preterm labor, and to select the appropriate time for delivery. Induction is safe. Preferred mode of delivery is vaginal in generally all the cases. After admission, you start with normal saline. If she goes into labor, then you add neutralizing dose of insulin to 5% dextrose. Routine insulin dose night can be given. Morning has to be omitted because now she will not be eating much. She's going under induction. She's going to labor. Start a 2-hourly monitoring first once she is in the intrapartum period. So initially you start with 2-hourly monitoring. Once she is in labor, intrapartum, then you do 1-hourly monitoring. Add insulin to normal saline if it is required according to the sliding scale. I'll tell you the sliding scale. If the patient goes into labor, now she will need glucose, okay, because now she's not eating. So you have to start 5% dextrose. From NS, you start to that, and her glucose is falling less than 70. You have to bring it to around 100. That was the question here. And the second option was right. So if it is less than 70, you give her 5% dextrose with neutralizing dose of insulin, and the dextrose has to be 100 to 150 ml per hour. IV drip of 1 liter, 5% dextrose with 10 units insulin is the neutralizing dose. But if the sugar is less than 70, then you have to GDM in ANC, ASAP or first visit? What? I don't understand your question. Recommended GDM in ANC, ASAP or first visit? Or you mean when you do a DIPSI? The DIPSI test is done at 28 weeks. That is a time when the patient is highly susceptible to the diabetogenic conditions of the pregnancy. Initially, first she comes, you do it. And if she has a history, if she's high risk, then you do a GTT. Otherwise, you can do a screening at 28 weeks. Okay. Now, ASAP we don't need to do unless the GDM is actually the blood sugar, random blood sugar is coming back more than 200 or more than after 2 hours glucose, it is coming to more than 140. Then you go for a proper screening. Okay. So, random blood glucose should be normal. Now, fetal monitoring, you have to do with Doppler, CTG, FBS and early cord clamping to avoid hypervolemia. Early cord clamping within a minute has to be done to avoid hypervolemia. Epidural is good for pain relief. If planned cesarean, again you have to omit the morning dose but give her the night dose of insulin. Now, cesarean is indicated if more than 4.5 kg macrosomic or any other obstetric indication. Sliding scale you need to know. If it is 90 to 120, that is fine. You don't need to add any insulin. Just give her NS. If it is 120 to 140, add 4 units. If it is 140 to 180, 6 units. More than 180, you add 8 units of insulin to the normal saline. That is a sliding scale. Now, coming to cardiac malformations in a fetus during a routine ultrasound scan at 16 weeks. So, you saw a cardiac malformation. Now, you know cardiac malformations will happen not in GDM. They will happen in overt diabetes when the HbA1c is above 6, above 6.5. So, what is the minimum amount of fasting blood glucose recommended by ACOG which can lead to cardiac malformations? Tell me. This question is important. Tell me the answer. KK is saying C. That's not correct. Okay. ACOG recommends that the fasting minimum blood sugar which can cause fetal malformations is 126 milligram per deciliter. So, the answer is B. Now, according to American Diabetic Association, yes, you're right, Sparsh Srivastava. Yeah. According to ADA, the criteria for diagnosis of overt diabetes is random sugar more than 200. So, you did a random sugar, it came more than 200 and there were classic symptoms of diabetes. So, that is overt diabetes. Fasting sugar more than 126, HbA1c more than 6.5 and 2 or more abnormal values after doing a DIPSI, 100 gram of oral glucose tolerance test during pregnancy. So, coming to DIPSI, which is the nationally recognized screening test for diabetes in India. So, we do a DIPSI. We do not call the patient empty stomach. I hope it is visible. Let me just zoom it. Yeah. So, whenever a pregnant woman comes for antenatal visit, irrespective of her meals, you do not ask her to come for like empty stomach. So, you do a 75 grams glucose test. Check her blood sugar after 2 hours. 110 less than 120 is normal. 120 to 140 is glucose intolerance. 140 to 200 is gestation diabetes. More than 200 is overt diabetes. This is how you basically diagnose GDM and overt diabetes. Now coming to, let me skip this question because there was a question in last year's INI-CET on lithium. Now lithium, because it is coming basically in the criteria of psychiatry. So I just wanted to include this because even I had to consult the psychiatrist to answer this question for you. So you people asked why we are decreasing the dose, why we are not increasing the dose. So the answer here is because the patient is on lithium and she is in the 3rd trimester. In the 3rd trimester, there is a lot of fluctuation in the doses of lithium because initially because of GFR increase is there in the 2nd trimester. So a lot of lithium goes out of the body. So in that case, the clinicians are inclined to increase the dose of lithium. If at all she is already maintained on lithium, then you may increase slightly in the 2nd trimester. 3rd trimester and after delivery, the dose might go down. So in that case, you are saying B, increasing the dose. The answer is actually decreasing the dose. It's actually decreasing the dose. Okay. Why? Because she is taking 750 milligram and she is well maintained. She has had no seizures. So you can decrease the dose in 3rd trimester. In this question, the next question, you may increase the dose because she had a history of 3 to 4 exacerbation episodes. I'm not reading the entire question because it's just the same. She is on lithium. She is in 3rd trimester. The first one was well maintained, did not have any seizure in last 1 year. This one has had 3 to 4 exacerbations. In that case, you may increase the dose. And the answer is because lithium fluctuations are too much, especially in the 2nd trimester with increased GFR. In 3rd, it may lead to toxicity. So in that case, you may decrease the dose if she is well maintained. Okay, you don't have to change to sodium valproate if she's well maintained. So this is what the answer is. That is why I included this question, because it is probably a high yield question because it has come twice. Then coming to this question. Okay, shall I do this question for you? Because this was just last year's question and this was nothing. You cannot actually pinpoint as to which chapter they are asking. It is just a very, very INI-CET level of question. You have to use your brains and think what is the answer. And can you answer this for me? If you know the answer, then I'll tell you how this question has to be approached. 25-year-old lady had an uneventful vaginal delivery. On postpartum day 1, she presented with PPH, complains of visual change and a severe headache. So it is definitely what? It is PIH. A few hours after the complaint, she is found to be unresponsive state. She is intubated and put on ventilation. So suddenly she had PIH symptoms, PPH also. So she had hemorrhagic shock also, and her blood pressure has gone down to 60/40, very, very low. So that is hemorrhagic shock plus she's unresponsive. She's on ventilation now and she has tachycardia, hypotensive shock. It is hemorrhagic shock, tachycardia will be there. Blood sugar is very low. This is something very, very unusual. We don't generally deal with such cases in gynae. Blood pressure can go low because of hemorrhage, PIH can happen, blood pressure can go up and down, whatever. But why sugar is so low? Hematocrit WBC count were normal. Okay, so there was no infection. Hematocrit is normal. So there is no hemorrhagic shock as such. Hematocrit is normal. Which of the following drugs would help reverse this state? Tell me. First answer the question, then I'll tell you as to how to approach it. It is definitely a multidisciplinary approach question. It cannot be simply solved by a gynecologist. It has to involve a physician, an anesthetist. So, postpartum pituitary necrosis, okay? That is what you think? Okay? That's probably what is causing blood sugar low? Low blood sugar? So, what will you give? What is the answer? It can be pituitary necrosis. Everything is going low. But why blood sugar is low? I'm just thinking. What is the answer? Tell me. Okay. The answer is steroid. In emergency, whenever you have to do something, you have to basically save the patient. The life-saving drug is steroid. It has to be steroid. Injection, dopamine, thyroxine, activated protein C, they have no role here. They all will fluctuate the blood pressure, I'll tell you. This is a case of postpartum shock, probably due to hypoglycemia and blood loss. We don't know why hypoglycemia happened. There may be an element of preeclampsia as well. The motive is to bring the blood pressure and blood sugar up, otherwise the patient will die. Dobutamine should not be used in this condition because it causes peripheral vasodilatation, resulting in decrease in diastolic blood pressure. So dobutamine, it will cause dilatation and further decrease the blood pressure. Things which are in favor of steroids are fluid retention. Transfused fluid will be retained, leading to rapid increase in blood pressure. That is what steroids do. The adrenal steroids, what do? They increase the blood pressure. Adrenaline, they all do that. Gluconeogenesis, yes, it will increase the blood sugar. Although additional vasopressor in the form of noradrenaline will also be required. Not just steroids, you may need noradrenaline also. Dobutamine will increase the systolic blood pressure, but it will decrease the diastolic, so it is not given. Steroid will increase the sugar also as well as the BP. So steroid is a better answer. Last slide for today, or probably the second slide. Second last. Partogram. This was requested by you all. We do not know, ma'am, how to basically assess a question of partogram. Now, this is part 1. Okay, can you see? This is part 1 of the graph. Part 1 is including fetal heart rate. It is including amniotic fluid. Part 2 is showing us the cervical dilatation and descent. And it is also showing us the R's. Okay. And part 3 is showing us the contractions per minute. Oxytocin is not mentioned here. It is blank. And it is also showing the pulse and the blood pressure and the drugs given. Drugs is blank here. You can see the pulse and BP is kind of static. The pulse is between 80 to 100 maximum. The blood pressure is 110/70, 110/70. So that is normal. Coming to the third part, you can see the contractions. These are moderate contractions. Mild to moderate contractions till about, you can say, 4 hours. After that, they became very, very strong. So what can you see here? What can you see here? The main thing that we see, remember, the main thing that we see in a partogram is the cervical dilatation, and that is being plotted with the help of a cross. The descent of the head is 0 and it is not shown here. 0 means O. That is a mark that they have to give. So they have not shown that. Cervical dilatation, they started plotting at 4 centimeter because the new modified partogram, WHO partogram, says that the active phase starts at 4 centimeter. So the plotting has to start at 4 centimeter. So 4 centimeter they started plotting, and after around 4 hours, so this was 0 hour, after around 4 hours, it was done again and it was around 6 centimeter. So there was a slight increase. So this patient is lying not on the left of the alert line, but it is lying in between the alert and the action. This is actually action. This is action line. And we know the difference between action and alert line is 4 hours. Okay. So the second PV examination showed a 2 centimeter increase. So they may have started oxytocin, although they have not mentioned, but the oxytocin was not required because she actually had a very, very strong contraction building up. So now what does that mean? She's not dilating. It's a flat graph. For the next 4 hours, it is flat. Strong contractions. Meconium is happening. You can see the amniotic fluid was clear till here, and now it is becoming blood stained, and the last two readings are meconium stained. And can you see the molding? It was +1 here. Now it is going to +2 and +3. Typical question of what? Typical question of, you tell me the answer. I will not show you the options. You tell me what it is. It's a straight line plateauing after 6 centimeter dilatation. Typical definition, after 6 centimeter dilation with ruptured membranes, with molding growing up to grade +2, +3, with very good contractions, not dilating. What is the diagnosis? She delivered with a cesarean section. What is the diagnosis? Tell me. KK. Who else is there? Sparsh. Abdul. Abdul has gone probably. Who else was answering initially? Tell me the answer of this question. I'm not giving you the hints or the options. And this is the second last question. Then one more question and we are done. Come on, KK. Waiting. Rahul Soni, you were also answering very well. I've given you all the hints. You've seen the partogram. Now you know what is happening. Okay. Okay, I'm not getting any answer, guys. Is it a lag of YouTube or you're not able to understand? A straight line in between the alert and the action with grade 2, grade 3 molding, strong contractions, meconium staining, not dilating. What do you expect? And the fetal heart rate going down. It was 140 and then it came down to 130 and now it is up to 90, 100. Come on. Okay, let me show you the options. Now can you tell me? Now can you tell me the answer? Is it CPD? Is it inadequate uterine contraction? Is it prolonged latent phase or is it none? I'm not going to give you this answer. It's very simple because I've explained the entire graph to you. This is how you have to see the graph. Come on, guys. Is it CPD? Is it inadequate uterine contraction? Was it inadequate uterine contraction? You saw such solid squares here. See, solid squares. Solid squares means very, very strong uterine contractions. So it is definitely not inadequate uterine contraction. Very good starters. Thank you. I was amazed nobody's answering. It is CPD. It is cephalopelvic disproportion molding grade 2, grade 3, meconium happening. So much contraction is there that the doctor doesn't need to give oxytocin. There is no dilatation for 4 hours. I'm wondering why they waited for so long. From here till here, they should have just seen that it is a plateau and they should have just gone for a cesarean section. But because it's a question being put up for you, so they have done a proper 4-hourly monitoring. So at 4 hourly and then 8 hours, it's around 4 hourly. 3 hours later, it was kind of after 6 centimeter dilatation. That is the definition of active phase arrest. So yes, it is CPD. Okay. Now, how do we actually assess the partogram? First part is fetal heart rate, amniotic fluid and molding. Everything was shown here. Second part shows cervical dilatation and fetal head descent. This was not shown here. Okay, but cervical dilatation after 4 centimeter. Alert line, action line, there's a difference of 4 centimeter in between, 4 hours, sorry, in between. Latent phase, now that's the definition you need to know. ACOG and Williams, they say that latent phase will end at 6 centimeter. Active phase has to be plotted after 6 centimeter. WHO graph which we just saw, the modified partogram, it is still showing the older WHO guidelines that the active phase starts after 4 centimeter. So you start plotting after 4 centimeter. But Williams has come up, WHO has come up with recent guidelines which have not been updated in partogram. They say now it is 5 centimeter. So 4, 5, 6. 4 is what we are following. 5 is the new guideline which will come very soon. Williams and American guidelines, ACOJ, Williams has American book. They are following 6 centimeter. Now, third part will show you the number and the duration of contractions which was seen there, right? Oxytocin dose, drugs, IV fluids, pulse rate, blood pressure, temperature, urine output. These are all the third part of the partogram. Most important is the number and the duration of contractions and whether oxytocin given or not. Okay. Yes, Pranjwal, it is A. Right. So the answer is A, that is CPD. Then active phase arrest is only diagnosed if the membranes have ruptured and the cervix is more than 6 centimeter dilated. So in this partogram, they have shown everything. Cervix is dilated more than 6 centimeter. Meconium was coming, means it was membranes had ruptured. So that was active phase arrest for 4 hours. So either there is no dilatation for 4 hours. That was the typical case here where there were good contractions, or if the contractions were not good, they were just kind of colored like this only. But here actually there were solid contractions. But if it had been like this, then they will mention that oxytocin was also given. So after oxytocin also, if there is no dilatation with inadequate contractions with oxytocin augmentation, that is active phase arrest. Somebody asked me, do we get active phase arrest? What is active phase arrest? This is the definition. Okay. Now, management has to be as per condition. Partogram of arrest is a straight horizontal line. What happened here? So, if it is meconium, what happened here? Molding, then you don't have to wait for 4 to 6 hours. You simply go into cesarean. Okay. If there is no molding and there is no meconium, we can still wait. You may give oxytocin. Okay. Now, KK is saying WHO labor care guide 5 centimeter, modified WHO 4 centimeter. Very good. Last question for today. Very, very simple. Nursing assistant posted in the obstetric care unit was asked to plot a partograph to monitor the progress of labor. After how much dilatation should she start plotting the graph? Simple. Let me check. This is the last slide.